Good to see you all here. We acknowledge the Kaurna people are the traditional custodians of the Adelaide Plains and pay respects to the elders past, present and future. We recognise and respect their cultural heritage, beliefs and relationship with the land. We acknowledge that they are of continuing importance to the Kaurna people living today. Now, I'd like to introduce Professor Adrian Esterman. He is our leading expert in the COVID-19 epidemiology, both in Australia and internationally. He has a PhD from our own site here at Flinders University in epidemiology, an MSc in medical statistics from the London School of Hygiene and Tropical Medicine, and a Bachelor of Science with honours in statistics from the University of Bath. His career includes 5 years as a WHO staff member based in Geneva and 2 more years in Copenhagen. He has over 400 career publications and is currently a chief investigator on several MRFF and NHMRC project grants, an ARC linkage grant, as well as several industry grants. He has over $15 million in grant income over the last 5 years. Now, please join me in welcoming Professor Adrian Esterman, who will be talking about what COVID-19 has taught us about epidemiology. And I'll just point out that there will be a microphone going around at the end of the session. We'll have some time for questions, as well as please submit them through your Hoover app. But please welcome Professor Adrian Esterman.
Thank you very much for the introduction, and it's nice to be back at Flinders. It's been about 17 years, I think. So the first thing what COVID-19 has taught us is that epidemiologists are now well known. I mean, who'd even heard of them before? And we used to sit in our little offices and no one knew about us, and of course these are some of the well-known faces you see. And so I'm going to start off by not talking about COVID, but talking about really how on earth did we get to the stage where epidemiologists are now media stars. And what happened was in January 2020, I've always had an interest in infectious diseases, and I worked closely with Professor Marmion on developing Q fever vaccine, for example. So when this new disease came out in the papers, some sort of respiratory thing happening in China, I immediately got interested and read up all the newspaper articles and the 2 or 3 published papers on it. That's all there was then. By the way, there's now over 300,000 published papers on COVID-19. But in those days, it was very small. But I read up everything I could, and by the time I'd done that, I was probably one of Australia's leading experts in COVID-19 because there was almost nothing known about it. But I kept being asked by colleagues and friends and family, do we wear masks? Do we wash our hands? Is there going to be a vaccine? So what I thought I'd do is I thought I'd actually write a story with all this information in. And I was looking for somewhere to publish it and came across this website called Medium. I don't know if you've heard of it. It's a very nice website, and basically you upload stories to it and you advertise it and people read your stories and you actually get paid for the stories. It's like 2 cents for every 1,000 reads. So much to my amazement, I had several thousand reads here's my actual first story there, COVID-19 Facts and Fiction, which you can see was done in July 2000. And much to my amazement, I had several thousand reads and earned about 15 cents. So I immediately wrote some more stories for them and again had more thousands of reads. And I was trying to think, well, how can I publicise it and get even more reads and even make perhaps $10? And I'd remembered that I'd actually put my name down for Twitter in 2014. And here's a typical sort of Twitter page. And our university has been pushing me and pushing all staff to use social media. And I was very, very reluctant. I mean, I'm too old to use social media. I don't want to sort of big note myself, and I simply couldn't be bothered. And, despite the fact that I joined Twitter in 2014, I'd never used it. I had no followers, never done a tweet. But I thought, well, I'll tweet about, my Medium stories. And within about a day, I had a follower. It was quite amazing. So basically, this is, as I say, a standard Twitter page. And over there, you can actually have your profile. And this is my profile on Twitter. And very important is what you say about yourself. Because if you put something interesting, you tend to get more followers. So you can see I put down, I'm an epidemiologist, ex-WHO. And I say it's more fun to talk with someone who doesn't use long, difficult words, but rather short, easy words. But very importantly, I say opinions are my own. Now, why have I said that? Well, it's because everyone else says it. So just about every profile page on Twitter, it says opinions are my own. And I've been thinking about this. I mean, I didn't say opinions are my own when I first started talking now. So the question is, does it really make any difference? And is it got any legal sort of responsibility? Can someone sue me? I really don't know, but it's a good point if someone's a lawyer here to actually look at that. So apart from your profile page, Twitter also has an analytics page, which you get through those 3 dots. And here's my fairly recent, about a week ago, analytics page. And so you can see in 28 days I made 285 tweets. Over 2 million people read my tweets. Over 500,600,000 people visited my profile page. I was actually mentioned in other people's tweets over 3,000 times. And I've got 38,000 followers. It's now a bit more than that because this was about 2 weeks ago. So what do I actually tweet about? So this is something I put out last week, and it talks about the weekly statistics that is now being produced by the different state and territory governments. You can see it's been retweeted 171 times. The other things I tend to tweet about are any news or interesting papers about COVID-19. So here's a typical one. Anyway, it turns out, I'm not sure whether you've ever heard of a website called The Conversation. So The Conversation, it's articles written by academics, basically, and it has some of Australia's best editors and journalists working for them. And if you want to have an article in The Conversation, you have to make a pitch to the editors, and they'll look at what you're proposing and decide whether they're interesting or not. But what happened with me was I actually got contacted by the editors and asked to write an article about COVID-19. I imagine it's after they saw one of my Medium stories. So here's The Conversation, and here's the first article I wrote for them. And again, much to my amazement, it got thousands and thousands of reads. So that got me hooked on The Conversation. Now, like Twitter, The Conversation has got sort of an analytics type page, and here's my one for The Conversation. And you can see so far I've written 28 articles for them. I've had 2.5 million reads of the articles, and I'm one of their favourite authors. The other thing that's happened because of all this media, and if you ever want to get on television or radio to publicise your research, write an article for The Conversation, because it's widely read by journalists. So I've been on television usually about once a week, if not more than that, for the last 2.5 years, although it's eased off now, which is good, because it means that COVID's dying down a bit. But, you think, and I'd never done television before, so the first time I did it, I was really, really scared, silly. But you think it's glamorous. It's not glamorous. It's awful. To give you an example, all right, I was asked to go on The Drum on ABC. So I went to the Collingwood studio, and they put me in a tiny little broom cupboard. It was pitch black, and I was sitting on a very tall stool with no footrests, facing a camera in the dark. And I had to sit there for an hour for this stupid thing, for 5 minutes of talk, It was not very pleasant. Far more fun is radio, especially talkback radio, which I really enjoy. So, for example, I was doing talkback radio, and a woman phoned in and said, look, I've just had my second vaccine shot, and it put me in bed for 2 days. Is that normal? And I explained that simply meant that your immune system's working properly, and it's reacting to the vaccine, which is fine. That all went well. And then another caller came on. Look, I've just had my shot, and I didn't have any reaction. Does that mean that it's not working? So you really have to sort of be on your feet when you're doing these talkback radio shows. This is why I do it. You get tweets like this and emails, and you think, well, at least someone's enjoying it. But let's actually now come to COVID itself and the main reason why you asked me to talk. I'm sure you've all by now heard of the basic reproduction number. So this says that at the beginning of an outbreak, so there's no one immune, everyone's susceptible to get the disease. It assumes that there's mixing in the population, everyone mixes with everyone else. Then this says that if you get infected, on average, how many people do you infect? So an R0 of 2 means that each infected person on average infects 2 others. Nice and easy. Now, you can actually calculate it at the very beginning of an outbreak or epidemic by actually literally counting how many people each person infects, if you can measure it. But it's very difficult. And so we tend to actually estimate R0 from mathematical modelling. And it's actually made up of 3 components, as you can see. How often do people contact each other? So how often does an infected person meet a susceptible person? The infectious period, how long is someone infectious for? And how transmissible is the virus? And it's this last one that's causing major issues at the moment in terms of measuring R0. And the reason is that there's 3 components to transmissibility. There's how fast the virus can replicate inside you. There's how well the virus can bind to your ACE2 receptors, because that's where COVID-19 or the SARS-CoV-2 virus gets into you. It latches onto your ACE2 receptors. And how well can the virus escape immunity? Now, that wasn't an issue for the original Wuhan strain, but as we see each new subvariant of Omicron coming along, it is more and more able to escape immunity. Also, these new subvariants actually manage to latch onto the ACE2 receptors a bit better. And the big problem here is that we know that these new subvariants are much more transmissible, and we know that they can basically do better at all 3 of those things, but we don't know in what proportion. And this makes it incredibly difficult to actually work out R0. Because, for example, the immune escape doesn't impact on R0, whereas the other 2 do. So because of that, it's almost impossible now to actually measure R0, which is a pity, because R0 is a function we use all the time in trying to work out herd immunity. Now, if you can remember, herd immunity is what percentage of the population do you need to be immune in order to protect the rest of the population? And it's a function of R0. So it's 1 minus 1 over R0. So if R0 is 0.5, you basically need 80% of the population to be immune. And of course, R0 is much higher than 5 now. We don't know how much more by, but it's probably somewhere around 12, if not higher. But this also assumes that if you get vaccinated, you get sterilizing immunity. That means that if you're vaccinated or, in fact, recovering from infection, you cannot be infected again. And this, of course, isn't the case. Unfortunately, both vaccination and recovery from infection, especially for these latest subvariants, gives almost no protection against being infected again. So we don't have this sterilizing immunity, and because of that, we were never going to achieve herd immunity, and we certainly can't now. Now, the other thing you've probably all heard of is the effective reproduction number. Now, R0's unrealistic once the epidemic started, because we have public health measures in place. We have a lot of people become immune because either they've had the infection and they recovered, or they've been vaccinated. And so the effective reproduction number adjusts for all of that. So it says, if you have a ref of 2, it means that for everyone infected, on average, they infect 2 others, given that there's public health measures in place, and given that there's a lot of immunity out there. And I'm sure you've all seen this. So the effective reproduction number is really telling us how well we're doing in terms of an outbreak or epidemic. So if the ref is greater than 1, it means that numbers are going up still. If it's equal to 1, it means that numbers have stabilised. And if it's less than 1, it means the epidemic's dying out. So how do you calculate ref? Well, again, it's usually estimated by mathematical modelling. But there's a very neat trick, which I actually discovered, and it's now been published, but unfortunately I never bothered to write it up myself. But it's this. If you take the moving average of daily cases for today, and divide it by the moving average of daily cases for 4 days ago, you get a very good estimate of the ref. And it ties in very nicely with mathematical modelling. Why 4 days? Because the generation interval for these current subvariants is about 4 days. It's probably more like 3.5, but approximately that. Generation interval is the time from me having symptoms and then passing it on to someone else who then has symptoms. What are moving averages, in case you've all forgotten your maths? I see we've got a lot of maths students here. You should all know what moving averages are. But it's very simple. So here's 7 days' worth of case numbers, and on the right is the average of them. And then we put the window down one, and you can see that we get a whole series of moving averages. That's how we calculate it. So I was totally stuffed when they decided to move from daily reporting to weekly reporting, because I then could no longer calculate the ref. But some very kind professor messaged me to say there is another way of calculating it on weekly data, and that's using this formula here. So you take this week's case count divided by last week's, the power of 4/7. Don't ask me how and why it works. Some of our mathematical friends here can probably tell you, but it does work. And what does the ref look like? Well, here it is until the beginning of September, and it's now, for South Australia, pretty much 1. In other words, we've come off this latest BA.45 peak, and we're now in the trough. Now, one thing about both the basic reproduction number and the effective reproduction number is their averages. It's the average number of people each case infects. But it's actually very varied. We have some people might infect lots of people, and others might infect very few people. And we actually measure how much variability there is by a number called K. So K is like a measure of dispersion or variability. And it turns out that if K is close to 0, then you get most people infecting no one, and very, very few people infecting a lot of people. In fact, almost no one. As K gets bigger, and here you can see it as 0.2, then you can see the number of people that infect no one has dropped from 80% to 60%, and you can see how that comes down. And so as you start getting K into 0.4, 0.5, then most people tend to infect the average number, okay, the effective reproduction number. Now, this means that there are assuming that K is close to 0, which in fact it is for COVID-19, this means that there are people out there who are super spreaders, who do most of the damage. So one of the reasons why this is important is because of contact tracing. You see, contact tracing is usually done in a forward direction. In other words, if you find someone who's infected, then you try and find out who they were in contact with, because those people are then exposed and are potential candidates for being infected, and you can isolate them, test them and isolate them. And that's how contact tracing works. But when you've actually got super spreaders around, you're actually better off going backwards and saying, well, let's try and find out the person who infected them. Because the person who infected that original case is likely to be a super spreader. So when you've got super spreading events around, what contact tracers tend to do is they tend to do both. They'll do backward contact tracing to try and find the super spreaders, and forward contact tracing to try and isolate those who've been exposed. So having said that, I mean, as I said, K in Omicron is around about 0.1, 0.2, so, which means we have super spreaders around. So what do we know about these super spreaders? Can we actually identify them? Can we locate them and, determine who they might be and then check them regularly? So here's what we know. Super spreaders tend to be male. They tend to be older. They tend to have compromised immune systems. They tend to be very sociable. They're always out shopping, etc. So a typical super spreader looks like this. So let's have a look at the current COVID situation in South Australia. The first thing is that I'm sure you're all aware that we've now got all of these subvariants of Omicron. In fact, there's over 300 now that have been identified. These are the main ones that have been hitting us. But what's not shown here is two new ones on the horizon, and that's BF.7 and BQ.1. And all of these, so 4.6, there's BA 2.75.2, which isn't shown here. All of these are far more transmissible than BA.5. One or more of them are starting to take over in countries like the USA, in India, in Thailand, in the UK. And you can almost guarantee that one of them is going to take over here. Okay, I don't think there's any question of it, and it's likely to happen before the end of the year. So it's not going to be like the BA5 situation, which took off like a rocket. I think it'll be a much slower takeover, but there will be a takeover, and we will see more waves. And by the way, in case you wonder why we always talk about BA4 and BA5 together, it's because they're almost identical. The only difference is in the body of the virus. The mutations in the spike proteins are identical, and that's why we talk about them together. So if you actually look at the 7-day moving average of daily cases for South Australia, we saw that at the beginning of the year we had the original Omicron, BA.1, which you see how steep that curve was, because there was so little immunity then to it. It just took off like a rocket, then died down just as quickly. But then we got hit by BA.2. I've no idea why, but we had that sort of two peaks, the twin peaks of BA.2. That died down, but not to such a high extent as previously. And then we got hit by the BA.4 and BA.5, which has only just now died down to its trough. And the trough has actually got much lower than I was expecting, probably because there have been so many people infected. So what's been the impact of it? Well, here's ICU admissions as a proportion of hospitalisations. And what we're seeing now is that for the last 2 or 3 months, it's been hovering around 3%. So 3% of people who've gone into hospital have ended up in ICU. But for some reason, over the last 3 or 4 weeks, it's gone up. I can't explain it. You people working in hospitals might be able to. But that's a little bit concerning. This is a picture of cases compared to hospitalisations. And I say cases lag by 1 week, and that's because people tend to go into hospital 1 week after diagnosis, or 1 to 2 weeks after diagnosis. And what we see here, it's quite interesting, is that around April there was this big disconnect between cases and hospitalisations. So cases went up by a rocket, but hospitalisation didn't go up anywhere near as fast. But now you can see they're actually tracking very well together. This is the 7-day average of daily COVID deaths. You can see here that we're still getting substantial numbers of deaths. The huge red spike at the end is because SA Health discovered a large number of deaths they'd forgotten about, and they sort of added them in the great big bolus, and it hasn't done things good for the graph. Testing. Okay. Here's what the 7-day moving average of PCR tests looks like. And as you can see, we're now getting to comparatively low numbers of tests on it every day. And this has got 2 reasons that I can think of. The first is that people aren't bothering to go for testing anymore. And the second is that SA Health has been reducing the number of hours that the PCR testing stations are open. And people have moved to a certain extent over to rapid antigen tests rather than PCR tests. So there's many reasons why this is happening, but nonetheless, it's not a good thing. So even though the Director General of WHO has said that there's light at the end of the tunnel, he's also said that countries should continue doing as much testing as possible. And we're not seeing that here. The other thing that's worrying is that as of a week ago, 14% of all PCR tests were positive. That tells us that there's still a lot of undiagnosed cases out there. WHO say that if it's more than 5%, then things are out of control. And we've had more than 14% for many, many months now. So I think what's happening is we're getting people, because it's winter season, they might have a sore throat, they think, well, it's just a cold, I'm not going to bother to test myself. Even if they test themselves, okay, they might not report the result if it turns out positive. And then when they do test themselves, the chances are it'll be a false negative anyway. So I think there's many reasons why we're seeing these things happening. I certainly wouldn't trust the diagnosed cases. We've probably got 2 to 3 times that many cases around. What about the rapid antigen tests themselves? Well, I'm sure you're all familiar with specificity and sensitivity. At least I hope you all are. So if we look at the reverse transcriptase PCR test, it's 80% sensitive and 100% specific. In other words, if you truly are infected, there's an 80% chance the test will come out positive. And if you truly are not infected, the test will find that's correct. What about the rapid antigen test? 80 to 95% sensitive and 90% specific. You might think, wow, that's not too bad. The trouble is that is benchmarked against the PCR test. So in other words, the true sensitivity of rapid antigen tests lies somewhere between 64% and about 80%. That means there's a huge chance of you getting a false negative result, and people don't understand this. That's why people like the FDA, etc., recommend doing serial tests. You do one now and one 48 hours' time. You're much more likely to get a correct result than look at an individual test result. What about progress in testing? Well, the first is we now have a rapid PCR test available. It's a Chinese test which has been imported into Australia. It's a bit bigger than a standard rapid antigen test. It takes about 55 minutes. It's the people who are distributing it say that it's as accurate as the reverse transcriptase PCR, but it's being tested around the country anyway by various groups. It costs about $40. It's not available to the general public yet. The distributors are saying they're waiting for the various government departments, etc., to try it out first, and then they'll release it to the general public. And of course, with greater volumes, the price might come down. But for people like emergency services, etc., it can be very, very handy. The other thing is we now have 2 combined COVID-19 flu rapid antigen tests. They take about 15 minutes, cost $15. And in particular, for influenza, it can distinguish between influenza A and influenza B. Something I wanted to mention was, one of the questions that we asked at the very beginning was how dangerous is it, if you touch a contaminated surface? And even now, you're seeing them having these big tankers going through the streets in China, sort of disinfecting streets. And there's a huge amount of emphasis on disinfection in institutions like hospitals and so on. But the fact of the matter is that almost no one gets infected through contaminated surfaces. This estimate, which is based on a big study, 1 in 10,000. So really and truly, we should stop worrying about contaminated surfaces and hand washing. I mean, hand washing is good for other things, okay? Don't get me wrong. But in terms of picking up a COVID-19 infection, it's not that important. Far more important are things like wearing a face mask and better ventilation. Vaccines. I get a huge amount of emails saying that people are worried about the safety of vaccines. I had one yesterday from a GP in the UK who basically was saying that this is all a big cover-up by the pharmaceutical companies and that they don't really work. In fact, they cause harm. The reason and the big problem is that we managed to get a vaccine in 12 months compared to 4 years, which was the previous shortest time period. But the reason we've done it is because coronavirus isn't new. I mean, it's been around for a long, long time. We've known the shape of it. China, to give it some credit, gave out the genome of it very quickly. We had massive money being pumped into developing a vaccine. And remember Operation Warp Speed in the US? And the other thing is that if you're familiar with clinical trials for vaccine development, you start off with preclinical studies, then you go into phase 1 trials, and then phase 2 trials, then phase 3 trials. And you don't normally start the next one until the previous one was successful. But in the case of these new mRNA vaccines, these things were done in parallel. They didn't wait. So they just assumed that the first one would work, while they were doing the second one. That's how it was sped up. And the other thing is that you normally have trouble getting volunteers for these trials. They had no trouble with COVID-19. These vaccines are safe. It doesn't mean to say people don't die from being vaccinated. They do. But it's extremely rare. So, for example, out of the umpteen millions and millions and millions of vaccines, COVID-19 vaccines that have been given out in Australia, we've had 13 deaths due to vaccine, 13, and all those people had something else wrong with them that caused the death. They are safe. Our TGA is incredibly conservative. So I'm sure you're all aware there's a bivalent vaccine available now, which has got the old Wuhan strain plus BA.1, which is about to be released in Australia, probably in the next month. And it is a little bit better than the existing Moderna vaccine. But in America and the UK, they've actually moved on to Wuhan strain BA.5 vaccine. And the question is, well, why aren't we doing that? Why are we waiting? How come America and the UK have moved on? The answer is that our TGA cannot approve a vaccine unless there are clinical trial results demonstrating that it's safe and effective. The only results that have come out for this new bivalent BA.5 are results based on mouse studies. There's been no human trial results yet. Despite that, both the UK and US authorities have approved it. So that's why our TGA are keeping us safe. In terms of effectiveness, this is what any of the vaccines basically looks like after 2 doses. So this is effectiveness against symptomatic disease. So you can see when you first get it, you've got 65% effectiveness against symptomatic disease, but that drops off rapidly over time until by the time you get to 5 or 6 months down the track, you've got very little protection at all. So what happens if you get a booster? Wham! Your protection goes right up to where it was at your second dose and stays even higher as it comes down. So every booster shot you get, it will wane over time, but that waning is getting, less and less fast. So you can see why it's so important that you have your booster shot, even if if you've had your 2 doses, usually those would have been several months ago, and by now you've got no protection at all, none. Having said that, this is what our current rate of booster shots are. In South Australia, it's 70% of eligible people. That means there's 30%, which runs into the thousands of people who've got no protection. Now, why is that? Why are these people not protecting themselves? Face masks. Now, there was a lot of controversy when COVID-19 first hit us about how useful they were. And what we know now is that cloth masks are pretty useless against these new subvariants. It's just too infectious. They will give you a little bit of protection, but not much. What about surgical masks? They give quite good protection. But respirators, or these P2 or N95 masks, give much better protection. And you get double the rate of protection compared to a surgical mask. Now, this is quite funny because I had to visit Flinders Private a few weeks ago. And I went through the sort of portal there and I got stopped because I was wearing a P2 mask. And the lady behind the counter said, "Sorry, but you have to wear a surgical mask." Worked that one out. So anyway, so recent huge study in healthcare workers compared the effectiveness of surgical masks to respirators and found respirators half the chance of getting infected compared to the surgical masks. Now, we know masks work. I don't think there's any question that they do work, especially sort of the P2N95 masks, to a lesser extent surgical masks. But do face mask mandates work? And the answer is not often. Now, that's a bit of a conundrum. So if the masks work, why don't face mask mandates work? And the answer is that simply asking people or telling people to wear a face mask isn't good enough. Even just coming up here today, I was walking through the hospital and the number of people who are wearing the mask under their nose, a total and utter waste of time. Okay, so you've got people wearing cloth masks, which are a waste of time. People wearing it under their nose, which is a waste of time. So it's not simply having a face mask mandate isn't any good unless you have very clear and sensible instructions to people as to why they should wear a mask, what type of mask to wear, how to wear it, etc. And that messaging simply isn't given out. So actually, I'm coming towards the end, which is a great thing, because I know we're short on time. So
I'm not sure I understand.
neither do I. So the joys of having smartwatches. So how can we take pressure off our health systems? Because I'm sure all being healthcare workers here, you understand that there's enormous pressure, especially with ambulance ramping going on. We're struggling to get people with elective surgery having it done. I think short term, we need to increase the uptake of booster shots. That 30% of people who haven't had it is outrageous, really and truly. And to do that, we need much better messaging to people as to why they need their booster shot. That messaging simply isn't there. We've had one campaign on television, which is a bit iffy, but we still had it at least, but then it stopped. We need to explain to people that they are not protected unless they get their booster shot. If they want to get COVID-19 or don't mind getting it, fair enough, but then they run a risk of long COVID. But really and truly, they should be getting or updating their vaccine status. And also much better messaging about face masks. In the longer term, as I said before, COVID-19 is an airborne disease. Okay, there's almost no chance of catching it from a contaminated surface. It's an airborne disease. And if it's an airborne disease, then we need to make sure that there's good ventilation everywhere. I mean, you don't drink contaminated water. Why would you want to breathe contaminated air? And that means that every factory, every hospital, every retail setting should have ventilation checks. If necessary, the high-volume air conditioners should be upgraded or sped up to refresh the air better. Or, if you can't do that, there should be air purifiers installed. My university has done that. So UniSA has gone through every single building, done a ventilation audit using CO2 monitors, upgraded the air conditioning where necessary, and installed air purifiers if that can't be done. I hope they've done that here and in Flinders University, because if they haven't, they should do. Better vaccines. We got these new bivalent ones coming along. Not only that, but even more important is there's several trials around the world now of vaccines delivered by nasal spray. Now, these could be a game changer, because these could actually stop infection. See, current vaccines don't stop infection. They don't have neutralising immunity. They won't stop from getting infected. In fact, not many vaccines will. Your influenza jab won't stop you from getting infected. It will stop you getting very ill, but it won't stop you from getting infected. These are a game changer. These can actually stop infection. We're awaiting clinical trial results, but this might be the next thing we're waiting for. On top of that, there's several groups around the world who are looking at getting a vaccine against all coronaviruses. Some of them are in quite advanced trials of it, not clinical trials yet, but if you recall, in 2020, we had no idea whether we could even get a vaccine against COVID-19. We simply had no idea. Now, we say the same thing about a pan-coronavirus vaccine, but I'm fairly confident we will get one. And that, along with the nasal spray, I think will put an end to COVID-19, which would be wonderful. And of course, we've got much better treatments, especially the antivirals. Unfortunately, we had a very slow uptake of antivirals. It's speeding up now, but it was a major concern. Last slide. Now, the British Medical Journal is highly conservative. It's also got a high impact factor, but it's highly conservative. The editors rarely make political statements. This is an editorial they had about 3 or 4 weeks ago. The National Health Service is not living with COVID, it's dying from it. The National Health Service is in deep strife. They don't have enough doctors, they don't have enough nurses. Heaven forbid you should try and get in to see a GP, you've got several week wait. Heaven forbid you should need elective surgery, you've probably got several years wait. That's the National Health Service at the moment. In the UK, there are no public health measures in place. You don't have to isolate if you're infected, you don't have to report if you're infected, you just go about life as normal, and this is what's happening. So I pose the question here, do we want to see this in South Australia? Do we want to see our health services totally stuffed? Because that's what will happen if we start going that same route as the UK and removing all public health measures. So I'll stop there. Thank you very much.
Thank you. I'm sure you'll all agree that that was an amazing talk. As reward of being chair, I might start with the first question. I have heard people say people I know say, I haven't got my booster because I had my 2 vaccines and then I got COVID and so I've got my immunity already. What do you think about that?
Yeah, so hybrid immunity is strong. So hybrid immunity is where you get natural immunity from being infected and you get vaccine-induced immunity. And it's actually more powerful than either of the two. But it still wanes over time. So, yeah, they'll get immunity against hospitalisation for a bit longer than you would get from not having hybrid immunity, but it still wanes. And yes, 7 or 8 months, they'll have no protection again.
I'll let them know. Okay, we have got some questions through on the Hoover app. So the first question is, will South Australia have a COVID-19 spike in November this year?
I think it's highly likely. The mathematical modelling by Professor Ross at University of Adelaide is estimating there'll be one anyway, purely because of waning immunity. But I think we're likely to have also one or other of these new and highly infectious Omicron subvariants is going to hit us, and that will also potentially cause another spike.
Another question from the app, particularly for the students. What career advice do you have for the Australian School of Science and Mathematics students with us today?
So my original degree was in statistics with a heavy maths component. It was a sandwich degree, which meant we had to spend 2 6-month blocks working in the industry, which I can highly recommend. And one of my blocks was with the Medical Research Council in London, and that's where I fell in love with medical statistics. It's a wonderful career. It really is. I've enjoyed every minute of it for the last 40-odd years, or 50 years even, okay? So there's plenty of if you're interested in medicine, there's plenty of careers in epidemiology and medical statistics and a huge demand for them. Way to go.
Okay. Do you have any comments about post-COVID? So maybe long COVID?
Yeah, so what we know at the moment from very large studies is about 12% of all infected people, whether it was a severe infection or a mild one, end up with long-term health problems. And we're finding out more and more issues. So much higher risks of stroke, higher risks of dementia, and the list just goes on and on and on and on. Something like 2% of the whole UK population have got long COVID now. It's going to happen here, and we need to plan for it.
We've got one more question on the Hoover, and then we might put the microphone out to the audience. Good question here. What are your strategies for communicating this information to members of the public who shout "cover up"? How do we communicate this in an accessible and non-condescending way? Do these people actually listen to you?
Well, I've got quite a few Twitter followers who do listen to me, but the true anti-vaxxers, the true believers, these are beliefs, okay? Just like religion is a belief, okay? You can put all the facts under the sun to them, and all it does is it reinforces their beliefs. So there's nothing you can do. For people who aren't the true believers, these are people who might be sceptical, but they're not sort of anti-vaxxers or conspiracy theory believers, then you can get really good messaging that can explain things simply. A lot of people are afraid. People are sick of politicians, okay? They want things explained very, very simply. Why should they do certain things? Just exactly what is the risk, put in simple terms. How can they actually protect themselves? And that sort of messaging simply isn't given out there.
And I think, we've seen the slides today how good it is to have our celebrity epidemiologists to pass that message in using short words in particular. Now, do we have some questions from the audience?
Hi, Adrian. My question is, how can data help? Is there a need for more data, better quality data, more surveillance, more understanding of patient risk factors?
There's always a need for more and better data, and there's no question of it. The trouble is that the government's going in the opposite direction. Rather than giving daily reports, we're getting weekly reports. And there's no consensus, so there's no standard definitions of things. So even if you measure weekly reporting, most states go from Friday to Friday, Queensland doesn't. There's simply no consistency. And the only way we're really going to get consistency is if we get our own CDC. Now, the current Labour government and the Greens, as part of their policy platform before the election, said they would support developing Australia's own CDC. And, and if any of you got mates who are politicians, please push for it, because we desperately need it.
Thank you. That was a really great, informative presentation. I did put it on the Hoover app, but do you think that lockdowns will be a thing of the past, or do you think that the new subvariants will trigger future lockdowns?
Look, you can never say never, okay? I think if we're looking at the SARS-CoV-2 virus and COVID-19, I think it would be most unlikely we will need to move to lockdowns again. We needed them desperately in 2020 because we didn't have a vaccine. But now we've got vaccines, which might not be perfect, but they still work to a certain extent. And that will be true for just about any other strain of SARS-CoV-2 that comes along. But it doesn't mean there's not going to be a new sort of virus going to hit us in 5 years' time, which is totally different. It might be a type of flu, it could be a type of hemorrhagic fever, and then we might need lockdowns again. So with COVID-19, no, I doubt very much if we ever need lockdowns again. But in future, for future pandemics, almost certainly.
Got some questions from the students?
Just wondering, what are we doing now to prevent future pandemic? Like, what are we strategizing now, like new vaccines, or what's the plan to like future pandemics in like 10, 20 years' time that may happen again? We've seen it happen before, it probably will happen again, but what are we doing now to, like, instead of being in a rush to make a vaccine, what can we do now to ease it up a little bit?
Look, in a sense, this has been a wake-up call and has prepped us for future pandemics. We now know how to handle these things with lockdowns if necessary, with other public health measures, with closures of borders. We've now got, or at least we're building in Melbourne, our own mRNA vaccine centre, which is fantastic because it means we can build vaccines very quickly for future viruses. The government was caught hopping with this one in terms of stocks of PPI, for example, and I think that will change. As to whether we've got an actual plan for future pandemics in Australia, I doubt it. A CDC would certainly do that. I know that there are groups around the world looking at the most likely next pandemic that's going to happen and looking at what we might need in the way of antivirals and vaccines, but I'm not sure if that's happening in Australia.
Hi, amazing presentation, by the way. This might be a really simple question, but I'm just curious. So you describe this vaccine as having quite a short waning period, immunity goes away quite quickly. What's different about this vaccine to have that short waning period over something like a tetanus vaccine? Why do I only have to have a tetanus booster, once every 8 years or something like that? But why do I have to have a booster, 3 months after my first one? I was just wondering.
Sure. I think you need to ask an immunologist that question. But clearly, some vaccines give you lifelong immunity. Others give you long immunity, many, many years, but then you need an adult booster. And some wane very quickly, like influenza vaccine and these COVID-19 vaccine. As to the actual reasons why, I'm not an immunologist, so I really couldn't tell you.
Hey, how you going? I got a question, and that is, how come the third booster shot is being administered to people over the age of 16, and will that age bracket reduce?
Okay, so we keep changing these age limits for different vaccination shots based on all the latest evidence that comes out. So ATAGI and the TGA are constantly monitoring what's happening around the world. You might not realise this, but ATAGI, who is a technical advisory group, are in constant touch with both the UK and Israeli health authorities, who are leaders in this area. And so they're constantly watching the most recent studies that are going on. And if, for example, a study finds that it's safe to give a vaccine to, let's say, 16-year-olds, then that's what then gets recommended. So it's just all based on evidence that's around there.
Okay, I have been told that's the end of our question time, which is a pity because I had about 10 more questions to ask Adrian. So please join me in thanking Adrian for an amazing talk.
Not a problem.
And I'll bring Simon up to introduce the next session.
Thank you very much, Professor Erin Simons. So, this gives us a chance to stretch our legs. The next session we have is our free papers session, and that will be chaired by Dr. Dylan Medant. So that will be commencing shortly. Thank you very much.
feel like it'd be unfair to start a minute early. Good afternoon, everyone. My name's Dylan Mordaunt. I'm the Clinical Director of the Women's and Children's Division at Salin. I'd like to welcome you all to the Health Services Research Day free paper presentation session. Shortly, I'll introduce the speakers for today. I'd like to start with an acknowledgement of country. I'd like to acknowledge the Kaurna people are the traditional custodians of the Adelaide Plains and pay respect to elders past, present and future. We recognise and respect their cultural heritage, beliefs and relationship with the land. We acknowledge that they are of continuing importance to the Kaurna people living today. So first, some ground rules, housekeeping, whatever you want to call it. The presentations are 8 minutes today, followed by a 15-minute joint Q&A. We're trying to keep as close to time as possible, hence starting bang on 2 o'clock. I'll introduce the speakers in a moment, but they'll be seated on stage, and we encourage you all to submit questions through Hoover as we go. To start with today, I'd like to introduce Dr. Stephen Batchy, Dr. Tamina Levy. Are we introducing all at once, or it's not a panel? Yep, no, is the short answer. And we weren't going to introduce the titles because we thought we were short on time, but I'll start by introducing that Dr. Batchy will discuss pre-stroke anticoagulation for atrial fibrillation in primary English speakers and non-primary English speakers, a multi-centre retrospective cohort study. Thank you, Doctor.
Thanks, everyone, for the opportunity to talk about this research, which is a statewide collaborative. So I think most people here know about atrial fibrillation, know that people with atrial fibrillation and atrial flutter are at an increased risk of stroke. And that in selected populations, with an appropriate risk profile, they can benefit from systemic anticoagulation to try and help reduce their risk of stroke. However, it's known that significant portions of the population who would benefit from guideline-directed anticoagulation don't receive this medication, and therefore this can result in strokes. If we can help to identify subsets of the population who are more at risk of not receiving this treatment, therefore more at risk of stroke, we might be able to help develop targeted prescribing interventions to help prevent strokes in future. One aspect of an individual's background that may contribute to their use of anticoagulation is their health literacy. It's been well described that health literacy relates to people's self-management of anticoagulation and various other aspects of their healthcare, including reduced access to preventative services. There's many things that contribute to health literacy, but one of these is having a language barrier. Clearly, we're in a primary English-speaking setting, and people who have non-English primary languages may have language barriers. And really, the existing evidence around how this may contribute to the use of anticoagulation for atrial fibrillation and how that relates to stroke is uncertain. This is uncertain globally, but particularly in an Australian population, which is why we conducted this study aiming to examine 2 factors. So aiming to examine the association between several demographic factors, in particular non-English primary language, and the likelihood of someone being on anticoagulation for known atrial fibrillation prior to being admitted with a stroke. In addition, we looked at people's adherence to anticoagulation in the setting of known atrial fibrillation prior to being admitted with a stroke. So this was a multi-centre retrospective cohort study of all the stroke centres in the state, Flinders, the Bra and the Lama-Kewan, and it included all consecutive stroke admissions over a roughly 5-year period. This study is dependent upon the ascertainment of a few key pieces of information. So in particular, atrial fibrillation, the way we ascertained known pre-existing atrial fibrillation was based on essentially a composite of multiple pieces of information available at the time of admission. So if someone was not known to have atrial fibrillation, they were found to have new AF after they've had a stroke, that was not considered known atrial fibrillation. This was people who had it in their past medical history, their GP knew about it, their families knew about it, they knew about it beforehand. Adherence can be evaluated through multiple different metrics, but again, we used a composite here, essentially the gestalt of a clinical team, collateral from GP, pharmacy, family about whether someone had been adherent, and that's what's recorded in the stroke registries, which is used to conduct this study. We conducted multivariable logistic regression for our 2 outcomes of interest and controlled for quite a few possible confounders or covariates. And most notably, we controlled for the components of the CHADS-VAS score, which has 2 VAS score, which is guiding indications for our anticoagulation in AF, and also some key contraindications to anticoagulation, including previous intracranial hemorrhage and peptic ulcer disease. And we conducted this analysis in Python R and had ethics approval from each of the participating centres. So when we looked at who was captured in this study, it was a large sample of over 6,500 patients, the majority of whom had ischemic strokes, which is not unexpected, that's well known. And up to a fifth of these had known pre-existing atrial fibrillation. One of the findings of real note is that a significant proportion of the people who had an ischemic stroke in the setting of known AF were not on anticoagulation, so 60%. Of those who had been commenced on anticoagulation, the majority were adherent. Now, whilst someone having an ischemic stroke in the setting of AF is generally attributable to the AF, there are some instances where you may have an ischemic stroke due to another cause despite having AF. So when we looked at the etiology ascertained by the treating neurovascular consultant, the majority of the cases of ischemic stroke were due to the atrial fibrillation. So when we looked at our population in terms of comparing those with non-English primary language and an English primary language, there were several differences. So there were differences in terms of age, gender, but most notably, there was no significant differences in terms of their CHADS-VAS score, so indicating the likelihood they should be anticoagulated, and key contraindications to anticoagulation, namely ICH and peptic ulcer disease. Now, it's notable limitation of this study is we did not have details on previous left atrial appendage closures, which is a way of reducing stroke risk in the setting of AF without anticoagulation. And we also didn't have details about frailty and falls risks, which can also influence anticoagulation decisions. That being said, when we compared the likelihood of someone receiving systemic anticoagulation for their known AF prior to being admitted with a stroke, there was a significant difference. So those with a non-English primary language were less likely to be on an anticoagulant for their known atrial fibrillation prior to being admitted with a stroke. And that was an odds ratio of 0.53. Interestingly, those with a marital status that was not married or de facto were also less likely to be receiving an anticoagulant for their AF prior to being admitted with a stroke. When we looked at adherence, there was no significant difference in those with a non-English primary language. Now, the confidence intervals there are quite broad. That reflects the fact that there were just fewer people with a non-English primary language who were actually commenced on an anticoagulant. That being said, there was no significant difference found in terms of the adherence of these patients. Again, the people who had a marital status that was not married or de facto were doing worse, though. They were less likely to be adherent with their anticoagulation for their known atrial fibrillation prior to their stroke. So I think that there's really 2 key points here. One is that there are subgroups of the population who are likely being underserved in terms of their AF management. This puts them at a risk of stroke. This study focused on those with a non-English primary language, but there are likely other groups as well. Really, this does identify potential inequalities in our healthcare delivery. These patients are receiving perhaps less standard care and putting them at risk of stroke. Now, it's interesting that we found that the people with non-English primary language were just as likely to be adherent. There are studies in other medications and other areas that have found that people with a language barrier are less likely to be adherent. That being said, based on our evidence, once these people are started, they will continue taking the medication at the same rate as everyone else, which just, again, highlights the importance of getting it started. Now, the people who are not married, not in a de facto relationship, there's evidence from other areas that these people are less likely to be adherent with medications. Reasons for that may vary. But the finding that they were less likely to be started in the first instance on an anticoagulant is new. Now, this was a retrospective study. We can speculate, but we can't ascertain exactly why these differences exist. I think it's reasonable to hypothesise that GPs under a lot of time pressure, language barriers around anticoagulation, it's a nuanced discussion, difficulty accessing interpreters, not being comfortable using interpreters, maybe differences in cultural values. These all may play a role, but further research is required to help distinguish the reasons for this. But ultimately, interventions are necessary. And we've identified an at-risk population that's potentially being underserved, and targeted interventions to improve anticoagulation prescribing in this group is required. Now, research in this area has suggested, actual studies in Australia looking at increased availability of interpreters. People actually tend to default back to using family as interpreters, the evidence would suggest. So we really need to interrogate how best to create interventional studies to change these outcomes. We do a lot of machine learning research. I think that natural language processing and the real-time translation will have an increasing role. Not sure it's quite there yet, though. But there is already available multilingual pharmacy and medication guides, but I'm not sure that everyone's aware of how accessible they are. I know that as a clinician, I haven't accessed them, when in retrospect I probably could have previously due to time demand and not being sure where they were. So really the take-home point from the study is people with a non-English primary language in South Australia are less likely to be on an anticoagulant for known AF prior to being admitted with a stroke. And I think further research and interventional studies are really required to ascertain why this is and try and help ameliorate this healthcare inequality. Thanks. Run off to a family meeting, but I'll come back for questions.
Awesome. Thanks, Dr. Becci. Dr. Tamina Levy will be talking on implementing group telehealth in a rehabilitation setting, exploring change of practice. Thank you.
Dylan. Thank you for listening to my presentation today, and I'd like to acknowledge my fellow authors for this study, which received an Allied Health grant at the end of last year. So there's a small but growing body of literature suggesting that group tele-rehabilitation has promising outcomes. That's mostly been done within physiotherapy and speech to date. This project was developed at the height of COVID, when we really needed to look at how we were delivering our services. So tele-rehabilitation was well established and embedded within ambulatory services at RAP. However, this was generally more in a one-on-one format. We know that there's many benefits of conducting groups in rehabilitation, including cost and efficiency, but also factors such as socialisation and peer support. So we really felt it was important to explore this in a tele-rehab setting. So our aims were to establish the current state of telehealth delivery across the ambulatory services, and also to support a change of practice by improving the experience and uptake of group tele-rehabilitation interventions. So we're really interested in developing a foundation for sustainability within the pandemic, but also beyond. So for AIM 1, we conducted an audit of service data over the 1 month period, and we were looking at establishing a baseline. So how much face-to-face was being done, how many groups were being conducted, and what sort of proportion of tele-rehabilitation was being conducted. In relation to AIM 2, we had a number of different research activities. So we conducted some focus groups, and they've been complete. We had an expert working group, which has been complete. And then we've been working on resource development, which is partially done. And once that's complete, we'll be doing some piloting. So just to step you through that process, we started with 6 focus groups, and these were conducted by an external research assistant online. And there was 23 participants, including 4 consumers and a range of health professionals. So once we had these recordings transcribed, 2 of the research team conducted an analysis of the content. And we used this behaviour change model to give this a strong theoretical framework. And from this we identified 6 themes. We then integrated those themes and we conducted an expert group. So this was an expert group with the research team, but also with 4 expert practitioners who had a lot of telehealth experience and 2 expert consumers who had participated in a lot of telehealth. So in this process, they did 2 rounds of voting. We did a lot of clarification about meaning and relevance to group telehealth. And really the 2 rounds of voting was aiming to give us information to prioritise what we needed to do to provide resources and processes to support group telehealth. So we took those findings and we presented those back to our external research assistant who developed a draft of some flowcharts and some process documents. And at the moment, that's where we're at. So these are currently with the research team, and then they'll be going to the expert team as well. And once we've got a finalisation of a draft document, we'll be doing some pilot testing. So what did we find? Well, in relation to the audit, so looking at AIM-1, so we looked at a 1-month period, so which was June 2021, so still in a fairly hectic COVID time. And we had 46 admissions in that time into the day rehab program, and 32% were receiving some form of tele-rehab, but only 6 of those were being conducted in a group session. So this gave us a good baseline. So as I said earlier, with the focus group analysis, we used a behaviour change model that gave us a strong theoretical framework. We used the COM-B model, which sits in the middle of the behaviour change wheel, which is a very strong in evidence. It's a synthesis of 19 behaviour change frameworks, which is used a lot in implementation science. So we use this as a base for our analysis with 2 researchers, and we developed 6 main themes. So at the top and the bottom of the 6 main themes, in the italics are the comments or some of the points raised by consumers, and then you can see each of the other points is themed as far as capability, opportunity or motivation. So first of all, there was issues around consumers interacting with technology. So that was around things about the iPad being a bit small or needing a carer to support them. This point around multitasking. So it's pretty busy. So they're trying to deal with the technology, and they're also trying to be responsive to the therapist who is asking them to participate in exercise, and they've got other people on the screen as well. Consumer interacting with the environment, aspects such as safety, concerns around the risk, the fact you're not in the room with someone. There was this issue raised of lack of privacy and dignity. So exercising in a group is not for everybody, and we need to be conscious of that when we're selecting patients to participate in group tele-rehab. The consumer confidence in the telehealth. Again, in relation to selecting the appropriate patients, if you had a patient who was, really not able to participate in the same exercise as someone else, that could be quite demotivating. So we need to be aware of who we're grouping together. In relation to the clinician issues, there was certainly, some clinicians expressed a lack of confidence. It was more of a new way of delivering a service. There was this aspect of divided attention, which of course we face that when we conduct other groups in rehabilitation, but the fact that you're not there and you're on the other end of a screen and you're trying to focus on more than one participant at a time is certainly an issue we need to be aware of. In relation to clinician performance, always going to be tech issues with this kind of platform. So that's something that we need to know. Well, how do we deal with these? What are the troubleshooting mechanisms we can introduce? And then the interaction between clinician and consumer. Things around, keeping it simple, not using jargon, those sorts of things were raised in this focus group. So in relation to the expert working group, and this was really, really great analysis and discussions and really aiming to give us priorities around where we needed to target our next stage of our research. So aspects such as people understanding why they're doing this, like what's the benefits of being in a group in tele-rehabilitation, keeping it simple, starting one-to-one, so probably face-to-face one-to-one, to be able to explain the technology, what are the processes, why they're doing it, what are the goals, but then also for the clinician to be able to establish a baseline, of that person's capacity to manage technology, but also their physical abilities to participate in a group. So that would be ideal, start one-to-one, face-to-face. How we prepare clients, again, needing to understand what the purpose is. People need reminders, so, you know, whether it's SMS or emails. There needs to be a basic level of ability of managing technology, and whether that's someone might need a carer with them to help support them through that. How we identify suitable clients, and I've raised a couple of issues around that, but how we group people together is really important. And what process we use to determine suitability. What just happened then?
You're on equal engage. Sorry, Tam.
I didn't push anything then. Sorry, just go back, sorry. Okay, one more, sorry. I do not know what happened then. It's got its own little mind. Having consistencies around staff and clients, so having the same staff working with the same clients. And again, problem-solving technology issues, very funny. Yeah. There we go. Yeah, there we go. So where we're at now is that we've got this draft document, which is including things like a flowchart and clinician resources. That's going through a period of consultancy, and once we've got that sort of a little bit more firmly done, we'll send that to our expert group, and then once that's finalised, we'll be able to pilot test that. And, you know, we really think this is something that can have wide range, wide scale applicability across health services. It might look something like this, with some sort of table of contents, some sort of flow chart. This one is probably a little bit busy, but these are the sorts of things we're working on. Thank you very much.
Thank you, Dr. Levy. Next up is Ms. Jo Nolan, who will be speaking on Salin Reduce, Delirium with Eat, Walk, Engage, Feasibility, Acceptability and Modelled Economic Analysis. Thank you, Jo.
Thank you, Dylan. I want to say it's great to be here. This is the culmination really of 4 years of work. 4 years ago, August 2018, Alison Mudge came from Queensland as a result of the Research Visitor Collaboration Scheme and talked about delirium, and in that time since we've obtained funding and run the program. So it's really great to have the opportunity today to talk about what we've done over the last few years, and I want to acknowledge all of the researchers on the slide who've been involved at different points. Can I work the technology? Yes. Okay, so I want to start by saying that REDUCE is actually an acronym for Translating Knowledge with Fundamentals of Care. So there's evidence that delirium can be reduced by 47% for patients 65 years and older who are in hospital for 3 days or longer. And as we know, that's a large proportion of the population for whom we care within our health service. The results of that were published earlier this year, but were known to the researchers before the Eat, Walk, Engage trial started in Salin. So Eat, Walk, Engage itself addresses the fundamentals of care for older people in hospital and is introduced at the ward level with a continuous improvement process and facilitators to support the local staff to do the things that need to be done for patients. This slide here, just as orientation, there's a graph of hospital-acquired complications from the Australian Institute of Health and Welfare, and it shows all hospitals for 2019-2020, and you can see that delirium is the most frequent complication of hospitalisation, far more than pressure injuries and far more than falls with harm. Now, patients come to us with individual risk factors. They might be older, they might be frail, they might be malnourished, they might have cognitive impairment. But the way that we care for them in hospital can contribute to functional decline and other complications such as delirium. If you think of the unfamiliar and busy and noisy ward environment, it can be quite confronting and quite difficult for many older patients to manage. So Eat, Walk, Engage is really an approach that addresses the processes of hospitalisation, and it promotes early, progressive and optimal nutrition, hydration, mobility and cognitive engagement that's meaningful to the patient. So it's not looking at the television, but it's finding out what means something to that patient and supporting them to access that during admission. So this slide is really to give you a bit of an idea of what happened during the Eat, Walk, Engage project in Salen, and as you can probably guess from the photo, it happened on Ward 4A. So we started looking at the local context and in every good improvement process collected some outcome measures at the start. We looked at interviewed patients at the outset about their experience of the fundamentals of care, and we did ward activity mapping and a meal audit in the ward. And this gave us the data to meet with the local team, the multidisciplinary team, tell them what was found and work out what strategies might help promote eating, walking and engaging for that ward, because not everything will work in every setting. In terms of resources, we had support from the Queensland team who developed the program, Alison Mudge and Prue McRae. And then I was one of the local facilitators a day a week, and Tiff Conroy with a nursing background was the other facilitator a day a week. And we worked with the ward multidisciplinary team. The project was happened over 17 months, and the last 10 months of the program we had the addition of an allied health assistant, not an allied health assistant, a multi-professional assistant half-time for 10 months. And that person, very importantly, took direction from any member of the team, from nurses, from doctors and from allied health. And they could support the team to do and implement the strategies that were challenging in terms of time. So the informatic in the middle is just a bit of an outline of the different things that happened at different times. You don't need to know the detail, but it shows that the team met every 4 to 6 weeks for the period of the project and some of the different strategies. Now the PET board, the picture there is of the PET board with one of the fantastic nurses and one of the fantastic patient services assistants. And that was a strategy that arose out of patients identified there was no destination for mobility. They didn't need to walk anywhere, there was nowhere to go, there was no destination. So the PET board was a means of providing a destination but also giving some meaningful engagement. So I could say, have you seen my dog Fred on there? Or you might say, my chooks are up on the PET board, do you want to come and have a look? So it's good for engagement and discussions between staff. So I'm going to talk about the feasibility, acceptability and modelled economic analysis in terms of the results of the project. So we know it was feasible because we did it, and we did it despite COVID. Despite COVID, we did have a brief pause from February for a few months, I think 3 months at the beginning of the project. But despite COVID and despite introduction of the electronic medical record, we were able to continue the project, to meet regularly and to implement strategies. Now, one of the process indicators that we looked at was in terms of the interviews. So we did interviews at baseline, midpoint and at the end. And the interviews at the end showed that there was a much better recall of patients remembering what the team, the whole medical team, had said to them about the importance of mobility, from 40% at baseline to 90% at conclusion. So that 50% improvement was very pleasing. And the photograph there is of a lovely nurse and lovely patient. And that patient, when he knew that he was allowed to get up and walk, he stood up and did 8 laps of the ward with his frame. So just telling someone that it's okay to get up and walk is really important, and something that's easy to lose in the busyness of working life. One of the key measures that we looked at and really was very striking was how many patients were sitting out of bed when their meals arrived in the ward. Now, there was a big improvement in this particular process indicator from 16% at baseline, that's for all meals, to 38% post-implementation. And that's despite virtually no change in the number of patients sitting out of bed at breakfast time, because guess when breakfast arrives? Double shift time for the staff, everyone's in handover. So 8 to 10%, the change in breakfast was from 8% at baseline to 10% at post-implementation. But there was a big improvement in lunchtime sitting out of bed for meals and dinner time sitting out of bed for meals. Do I need to? I'm hoping I don't need to explain why this is important. Food goes down better, people can open their packages better, and nutrition is better. And it's a photo of a lovely patient who really exemplifies, I think, the Eat, Walk, Engage, who loved sitting out of bed. She had a cap on her head, she had flowers from her garden, and she was playing cards. 1 minute to go. Oh, my goodness. Okay. I will move straight to acceptability. I won't read out all the acceptability quotes, but we looked at staff acceptability, and the last quote, staff said it's positive for patient care and it's positive for team building because it contributes to the whole team, and it was good. I think that we found the program worked well, we were able to implement it, but really important is to look at the economic analysis and what it would mean if it was implemented. So we did some modelling with John Carnan based on effectiveness data that was reported and using Salin Ward 4A data. So in one ward, in 1 month, 73 occupied bed days saved. The return on investment for that is calculated at 5 to 1. So really, I think it's pretty clear. Eat, Walk, Engage in Salin is feasible, it is acceptable, and it's positive for patients, for staff and for the health service. It contributes to patient wellbeing and staff wellbeing. And because of that impact on occupied bed days, I think it's really clear to me it has potential on impacting on flow. So the question is, where to next? It's really it's effective, it's acceptable, it's feasible, it would assist Salin in meeting accreditation requirements and fits with the Salin strategic plan. So my question is, when can we roll it out?
Thank you, Ms. Nolan. Up next, we have Dr. Amelia Searle, who will be speaking on screening for chronic pain in an emergency department, lessons learned from a pilot study.
Thanks, Dylan. Thanks, everyone. So this research was part of a cross-divisional collaboration at Salin. So myself, Cindy and Peter at the pain unit. Debbie McCarthy is the senior social worker in the Flinders ED, and Sharon Brown at Flinders Psychological Services. And the research arose because of the identified issues that ED doctors and the patients face when patients are presenting there with chronic pain. So internationally, about 10 to 16% of all ED presentations are due to chronic pain, and these patients are those that tend to re-present, so they account for a disproportionate amount of ED resources. However, the prevalence of chronic pain in Australian EDs is currently unknown. And chronic pain, as you might imagine, it's a chronic condition. This is an acute care service. It's difficult to identify and treat in EDs beyond that immediate and acute flare-up. Chronic pain, it might not even be identified as the presenting complaint. EDs use acute care ICD coding, which really doesn't capture chronic pain anywhere. And there are really few in-hospital treatment options unless you're talking about opioids. So, given this was a pilot study, our initial focus was on identification. We wanted a good sense of the scope of the problem, and we wanted to see if, screening might be a feasible way of addressing this. So our aims were to examine the prevalence of chronic pain in the Flinders ED and whether our brief screener was a feasible way of identifying. So we asked ED doctors to screen all of their adult presentations. Obviously, there were some exclusions, people who couldn't answer questions because they were critically ill or in an altered state of consciousness. And this was over a 3-month period, a very momentous period, September to December 2020. This was during the course of their normal patient assessment, and they used a 2-question paper screener, which is up on the screen, one that we developed. So doctors asked patients, do you currently have persistent or recurrent pain that's lasted longer than 3 months? This is the definition of chronic pain. And for those patients who said yes, they were then asked, is your ED attendance related to this chronic pain? The idea being that those people saying yes to both questions, those were our positive screens. We termed them chronic pain presenters. I should say, to actually conduct this screening, we conducted extensive education and engagement activities leading up to and during data collection. So we were doing presentations during weekly meetings for ED doctors. We were also doing briefings during morning handovers, multiple emails, flyers up around the ED, and Debbie, our social worker, was actively reminding doctors whenever she saw them on the floor, I think to the point where some of them might have been running the other way when they saw you coming morning, Deb. So we certainly put a lot of effort into getting the message out. And once we'd finished screening, we asked doctors to complete a really brief 5-minute survey on the feasibility, either on paper or on Qualtrics. So, as I said, we couldn't have picked a worse time for data collection if we'd actually tried. We were plagued with multiple issues that made data collection extremely difficult, but in the context of a pilot study, it did give us some valuable lessons learned moving forwards. For a start, regular staff turnover, as happens in the ED, but also just the regular day-night shift rotations meant we needed that near constant education to actually catch everyone and make sure they were fully informed about what they needed to do. As you'd know, the ED is and was frequently over capacity, so numerous code whites, code yellows. Obviously, screening is going to shift down in terms of priority. Good old COVID kicked in about week 5 or week 6, which actively interfered with screening procedures. One obvious point, bits of paper couldn't always be taken to bedsides because of droplet precautions. Anything else to throw in? Oh yeah, the extended care ED ward was relocated. It was unexpectedly brought forward during all of this. So we had all of that to contend with, let alone this being a busy ED. So, things were looking promising initially. We had screening rates go up to about 24% by week 4, but then with the numerous issues kicking in, COVID kicking in around week 5 or week 6, this went down to about 12%, and things sort of only got worse from after that. We were averaging around a 6% screening rate for weeks 6 to 12. So for that reason, any data analysis we've done moving forward has been on these first 6 weeks of the 3-month project, because we had a better response rate. It was 16% of all adult presentations screened overall. So yeah, when we're talking about valid prevalence estimates, that's not what this is. Nonetheless, we did have 1,325 screened presentations, so we do have data that's a starting point, and obviously we're treating it with a grain of salt. So we had, of the screened presentations and patients, because we did have some patients represent, 23% of screened presentations had chronic pain, and 23% of the patients. But we were more interested in not just the people who answered that first question, yes, I have chronic pain, but I'm actually at the ED today because of this chronic pain. And that was 8.1% of presentations and 7.7% of patients. And we also looked at re-presentations. So we found that of the chronic pain presentations, 7.5% were re-presentations, so they belonged to a patient who had already been screened and screened positive in those prior 6 weeks. And this was compared to all the presentations that weren't because of chronic pain. So those non-chronic pain presentations, only 2.3% were re-presentations, and this was a significant difference. So it kind of fits what we know from the literature. People with chronic pain tend to represent more than others. Moving on to the doctor survey results, there were about 25 doctors who did this survey, and not too bad considering the environment they were working in. We were plied with chocolates as incentives, so I think that helped. That was probably about a quarter of all doctors who could have actually done the screening. So of the doctors we surveyed, they all knew about the study. In fact, most of them said they'd heard about it through multiple sources, through various of our activities. So far, so good. And as you can see on the screen, the screener was quite acceptable. It worked quite well. They thought the questions were clearly worded. They felt confident administering it. They thought the patients understood it well. Wasn't too onerous on them, and they thought it had moderate future value. But, despite the screener being received quite well, they self-reported only screening about 45% of their patients. And these were the 25 doctors that had the time to answer our survey. So obviously this is an overestimate. And as you might imagine, the reasons they gave for not doing the screening were, being incredibly busy, forgetting, and the screening clashing with other ED procedures, including COVID procedures. And it was these kind of process-related barriers that were also echoed in the free text responses we had in the survey as well. So this project has kind of generated more questions than answers for us, and we're excitedly starting on a number of new avenues. But what we can say, we don't know how closely our rates actually mirror real-life prevalence, but we do know that chronic pain exists in EDs. We can see that there are people who turn up to this acute care service with a very chronic complaint. It's a non-trivial proportion, and so it does need future attention. Our screener, it did seem to identify chronic pain presenters fairly quickly and easy, but it was those process-related barriers that were really insurmountable in this kind of high-paced environment. So any unanticipated changes that happen during the course of research can just, really derail things, I guess. So if chronic pain screening did have a future, it might be better integrated within different ED processes, perhaps, one potential being even at nurse triage as they walk in, and we certainly get information entered into Sunrise around that, around presenting complaints as well. For our purposes, we were really keen on doing prevalence. Perhaps I was a bit naive in that aim. If you're wanting to do prevalence, you need universal screening, but moving forward, maybe doctors can do more of more intuitive screening. So this is probably going to be, screening only around 10% of their patients who they think this might actually apply to or capture, and that might be a little less burdensome for them. But something that certainly was missing from this research, and we're keen to examine moving forward, is the patient perspective. We don't well understand the reasons why patients present with a chronic complaint to an acute care service, and if we understood this better, we'd have a better sense of what barriers we could remove and maybe what treatment options we could provide. And this might be especially important for those re-presenters, because clearly for those people, out-of-hospital pathways just aren't meeting their needs if they're constantly rocking up to the ED. Obviously, people who do turn up to the ED, they do have some kind of acute crisis. They are looking for an immediate fix. But beyond that, if we know the reasons behind it, we might be able to prevent this from being the reason they turn up to the ED in future. And even aside from that, people might be interested, once that acute crisis point has gone, in taking up more longer-term self-management strategies, which might keep them out of hospital. And we're also keen on getting involved with the doctors and providing them a bit more education. Given their background is acute care, at the pain unit, we're keen to collaborate with them and educate them around the complexities of chronic pain and information and out-of-hospital pathways they might be able to then pass on to their patients as something to offer them for patients to take up when they're ready and when they're out of their moment of crisis. Thank you.
Thank you, Dr. Searle. Up next, we have Associate Professor Michael O'Callaghan, who will be speaking on variation in patient-reported outcomes following radical prostatectomy, a binational registry-based study. Thank you.
Thank you for the introduction. Good afternoon, everyone. Today I'll be presenting about variation following prostate cancer surgery, and this work is part of the Australia and New Zealand Quality Indicator Registry, and I present on behalf of colleagues from most states in Australia and New Zealand as well. So to start with, prostate cancer is very common. It's the most common cancer in Australia, and we can estimate there's about 24,000 new cases that will be diagnosed this year. It's very common indeed. The good news is that survival outcomes are excellent. So if we go back to the late 1980s, 5-year survival was around 60%, and that has risen up to the high 90s. For 5-year survival, which is really, really good news for men who might have prostate cancer. But what that does do is shift our focus away from survival towards quality of life after treatment. Because now we've got around 250,000 people in Australia living with prostate cancer. We know they'll live for a long time. It's about them living well. If we think about the treatments which are offered to men with prostate cancer, there's lots of different treatment types: surgery, radiation, very carefully managed surveillance, hormone therapy and chemotherapy as well. And each of those treatment types affects quality of life in different ways. And I've put up there an anatomical diagram where the prostate is in orange in the middle there. What you can see is that lots of organs sit very close to the prostate, and when they're treated, particularly by surgery or radiation, they are affected. and that's important to keep in mind. We'll have a look at some of those in a minute. So with this in mind, prostate cancer survival is good. There's lots of treatment types and quality of life is important. We have here in Salon an established quality registry to measure treatment of prostate cancer and the outcomes that men experience. And that was established back in 1998. There's currently more than 20,000 patients in the registry from across South Australia. And in that registry, we carefully measure clinical outcomes and also patient-reported outcomes in parallel so that we can see how men are feeling about the treatments that they receive. And this data set really underpins quality improvement research, research and quality improvement research. So lots of things all at the same time. The data we collect at a state level is de-identified and sent to a national registry. That was established in 2014 at Monash University and funded by Movember. And this has data on about 60,000 patients from around Australia and New Zealand. There's more than 350 clinicians contributing to that and more than 240 hospital sites. And the wonderful thing about this national registry is that we're able to benchmark for the first time how care is delivered right across the region and how individual surgeons, radiation oncologists and hospitals are faring when it comes to delivery of services and how patients feel about what they have received. So I've got here two particular quality indicators. We've gone through a Delphi process and come up with 12 specific indicators which are reported at a national level. But for prostate cancer surgery, particularly, two things are affected which patients report about frequently. One of those is urinary incontinence, and that's on the top there. And the second one is sexual function. So if you think back to the anatomical diagram of the prostate in the middle with the bladder above, you can imagine why urinary incontinence becomes an issue if the prostate is surgically removed. The innervation for the penis also passes around the prostate. If it's surgically removed, it's going to affect sexual function. So both of these things come up in our benchmarking reports. If you have a look at each graph along the bottom, there's a number from 0 to 100, which represents the function which men report, 0 being terrible, 100 being perfect. And the vertical axis represents how bothered people are by these symptoms. So 0% bother up the top and 100% bother down the bottom. So where we want to be is the top right-hand corner, which is not bothered and perfect function. And you can see that urinary incontinence at a national level is close to that, but not perfect, but particularly that there's enormous variation across the country. And the same with sexual function. We've got function along the bottom, 0 to 100, 100 is perfect, and we've got bother on the horizontal axis. With 0% bother up the top, people are happy. So where we want to be is the top right-hand corner. And you can see nationally, we are nowhere near that. That orange crosshair represents the median for Australia and New Zealand. There's a long way to go. And we can also see that there's enormous variation in the outcomes across the region. So the question that we set out to answer for this particular project is, what is determining the variation across Australia and New Zealand in the outcomes that men are reporting? So we went to the National Registry and we extracted from there 23,000 prostate cancer surgical cases who had completed 13,000 patient-reported outcomes questionnaires at 12 months after their surgery. So a very big sample was selected for this. And in that sample, we typically had a group of men who were in their late 60s who had a PSA for their blood test at about 6. They had intermediate pathology and they were treated by robotic surgery. So a very common description of a man who might have prostate cancer. So when we looked at urinary incontinence specifically, we saw that the median function score was 76 out of 100. So it's high, but there's room for improvement. And about 10% of men reported being very bothered by that. So 1 man in 10 who goes to have this surgery 12 months later will not be happy with the outcomes he has experienced. That's quite high. What we did is we had a look at different patient, disease, and health service factors that might contribute to this variation. So is it something about their disease? Is it something about the patient or something about the hospital or surgeon which contributes to this variation? And this is what we saw. This is a similar plot to the one we saw last time. And the one on the left uses different colours to indicate the volume of surgery that's happening at the hospital where they're treated. So if they're a high volume hospital, they have a dark colour. And what you'll see there in the middle of the plot is that those hospitals have better outcomes and they also have much more consistent outcomes. Whereas lower volume surgeons and hospitals tend to have worse outcomes and much more variation in what their patients are reporting. If we have a look at the plot on the right-hand side, we had a look at these same outcomes by patient age. And again, we can see that patient factors contribute. The dark colours represent older ages. They tend to be on the left, and the lighter colours are the younger ages that are typically on the right. So younger patients do better. Patients treated in high volume centres do better as well. So if we move along to sexual function, we can see some similar trends here. Firstly, the median score is very poor, right across the region, 29 out of 100 for function. That is not good, and it needs to improve. Almost half of the men were bothered by this outcome. So 12 months after their surgery, they're not pleased with what they've received. Half of the patients. We then set about to look at the same patient, disease, and hospital factors that might contribute to this. And we saw some similar patterns. High volume centres tend to have better outcomes and less variation. Younger patients tend to have better outcomes and less variation. And combined, these two factors explained 74% of the variation that we saw. An enormous amount of variation is described by these two things. So let's summarise. I think I've got 30 seconds left. Prostate cancer is very common. Surgical treatment of prostate cancer is common as well, and it does impact on patient experience adversely. If we measure the patient-reported outcomes, we can explain some of the variation in these outcomes by patient and service level factors. So why is that important? If we can optimise where patients are treated, in this case simply by moving patients to high volume centres, we will almost certainly improve outcomes right across Australia and New Zealand by a very theoretically simple health service change. We can also think about how we can start to manipulate patient characteristics. The one I presented today was age, and you might think, how can we actually change the age that a patient is diagnosed at? And in actual fact, you can, because the key determinant of diagnosis with prostate cancer is screening. If patients screen, they will be diagnosed earlier, and therefore they will have better outcomes. So I think there's enormous potential for these outcomes to influence prostate cancer treatment in the future and hopefully improve the outcomes which men experience. So thank you to lots of funders and to thousands of men and clinicians who have contributed.
Thank you, Associate Professor Michael O'Callaghan. Up next, we have Dr. William Hiddle, who will be presenting on deteriorate, audit of medical emergency team calls associated with recently initiated beta blocker therapy in heart failure and atrial fibrillation. Thank you, Dr. Hiddle.
Good afternoon, everyone. My name is Patrick, this is Brandon, and this is Jess. We're actual final year medical students just here to present under Professor William Heddle. And we're here to present our project, the Deteriorate study. So heart failure and atrial fibrillation are both rising cardiovascular epidemics and often cause a significant burden for patients and the healthcare system. Now, heart failure is defined as a chronic progressive condition in which the heart muscle is unable to pump enough blood to meet the body's demand, whereas atrial fibrillation is a type of arrhythmia, which means the heart beats fast and irregularly. Now, current atrial fibrillation guidelines recommends the use of beta blockers in hemodynamically stable patients with both diseases, and this is further supported by the current heart failure guidelines. But if the patient is hemodynamically compromised, then a beta blocker is not recommended and amiodarone is to be used first line. The guidelines, however, do not establish the defining factors that determine whether the patient is hemodynamically stable or not. Thus, the goal of this project and study was to improve the safety of initiating a medication that is known to have negative short-term effects by identifying the patient factors that can help define hemodynamic instability. Our initial hypothesis was that patients with concomitant heart failure and atrial fibrillation who were initiated on a beta blocker would have worse short-term outcomes. The project that we conducted was a retrospective cohort study between 2006 and 2018 of patients admitted to Flinders Medical Centre with either atrial fibrillation and/or heart failure. Our primary composite outcome was a 30-day all-cause mortality or readmission, and our secondary outcomes were 30-day all-cause mortality and 30-day readmission. These outcomes were assessed using a Cox proportional hazards model. The flowchart on the left-hand side shows the identification of our research participants. Using the focus dataset, we were able to identify 55,146 admissions with either heart failure and/or atrial fibrillation. Now, some of these were repeat patients, so we were able to consolidate these to 27,673 individual patients, and then further subdivide these into their underlying disease of heart failure, atrial fibrillation, or both as shown. This comprised our large group of analysis. Additionally, from the large number of records, we were able to identify 18,260 admissions who both had atrial fibrillation and heart failure. And then of these, 1,282 had a MET call during their admission. This was our identifier for hemodynamic instability. From these, we were able to case note review 79 of these admissions and to identify if a beta blocker was initiated or not. And this became our small group for further analysis. Thank you.
So firstly, focusing on the results of the large cohort of 27,673 participants, we found that the primary composite outcome of 30-day all-cause mortality or readmissions was significantly lower in the AF only compared to the concomitant group. But in the heart failure only outcomes, they were the same as the concomitant group as highlighted on the graph shown. When we assessed the rates of MET calls or deteriorations, there was minimal difference in the rates between all the groups. But of those in the concomitant group who did have MET calls, they were more likely to have the primary outcome of mortality or readmissions compared to those in the concomitant group that did not deteriorate during their admission. And this was significant. As such, what we've been able to demonstrate is in our local SALN data is that atrial fibrillation represents a large burden of disease, given the large number of annual hospital admissions or presentations in patients with atrial fibrillation over the time period studied. And having comorbid disease of atrial fibrillation and heart failure demonstrates worse short-term outcomes after hospital admissions compared to atrial fibrillation alone, which is what we expected given their having higher disease burden. However, it was interesting to see that patients with heart failure alone had similar outcomes as the comorbid patients. And this suggests that having heart failure is actually a larger contributor to determining the outcomes. What was also interesting was that whilst heart failure seems to contribute to poorer primary outcomes, it does not contribute to an increased rate of inpatient deteriorations or MET calls, as suggested by the similar rates across the groups. However, in patients with concomitant disease, having a MET call does seem to predict worse primary outcomes. And some limitations or confounders that we've noticed when we were assessing the data of the large group Firstly, we were reviewing data retrospectively, and we found that there was variability between the group baseline comorbidities, with some comorbid diseases more prevalent in the concomitant and heart failure only group compared to the atrial fibrillation only group. And that could have contributed to why there was a higher primary outcome rate. Secondly, as we were relying on the focus data set, we were unable to assess the MET call reasons for all the presentations and could only do this for the small group where we analysed the case notes. So as such, we don't know the details about the MET calls and the way they were managed or their outcomes.
Cool. We'll go through a small group now. So to reorientate, the small group are patients who had both heart failure and atrial fibrillation, and all of these patients had a MET call throughout their admission. We compared those who were initiated on a beta blocker to those who weren't. First graph I want us to look at is the graph on the left. It's our primary outcome measure, which was a composite outcome of 30-day readmission or mortality, with the beta blocker initiated group shown in red. Clearly there is a very large difference between the two groups. The second graph on the right is the secondary outcome of 30-day mortality alone, and it follows a very similar trend. And this shows that the large gap in primary outcome was largely made up by a difference in mortality. In fact, our 30-day readmission outcome didn't have a significant difference between groups. So to understand the importance of those results, it's useful to step back and think about what we knew first. So we knew that beta blockers have previously been shown to reduce long-term all-cause mortality in patients with both heart failure and atrial fibrillation. However, these weren't randomized controlled trials. The other thing we knew is that beta blockers are usually initiated when patients are in hospital. One study showed that 90.1% of patients with heart failure were initiated on a beta blocker whilst they were in hospital, as opposed to as outpatients. So the routine practice of starting beta blockers whilst patients are in hospital, as opposed to when they're an outpatient, adds significance or clinical significance to our findings that this is indeed safe, and in fact may result to better outcomes. But that needs to be considered in the context of our limitations. Firstly, patients weren't randomized to treatment, so there's probably a selection bias as to who got a beta blocker and who didn't. We also did this study throughout the COVID pandemic, which really restricted our access to patients' medical records. And that meant we had much smaller sample. And so we couldn't look at things that we wanted to look at, like what kind of beta blocker people were on, or patients who perhaps didn't have a MET call. Okay, so to conclude, our findings suggest that beta blocker initiation, whilst patients are in hospital, is safe and beneficial even for patients with both heart failure and atrial fibrillation. However, given our limitations, further research is needed to elucidate the optimal timing for initiating this drug. The other thing to mention is we initially set out to try to predict the patients who would deteriorate when initiated on a beta blocker, and we weren't able to, but it's something we'd like to learn in future. Great.
Thank you.
Thanks.
Thank you, team. And last up, we have Ms. Langzhou Chen, who will be speaking on exploring shared experiences of people with stroke and caregivers in preparedness to manage post-discharge care.
Thank you. Thanks for this opportunity to share the findings of this study. First of all, I would like to thank Professor Lily Shao and Professor Di Chamberlain for their support. They are the supervisors of my PhD study, and today's presentation is part of my PhD study. Stroke is a leading cause of adult disability in the world. With the advances of stroke management, more people with stroke return home and are cared for by their families. But they are not well prepared to take over and manage care after discharge, especially in the context of shortened hospital stays. So the aim of this study was to understand the shared experiences of stroke dyers in their preparedness to manage post-discharge care. This study applied an interpretive approach underpinned by Gadamer's philosophical hermeneutics. Gadamer described the interpretation process as a hermeneutic circle. The inquirer enters the interpretation process with an open mind and with a pre-knowledge of the phenomenon. Gadamer emphasized that a deeper understanding can only be achieved when the inquirer consciously identifies, provokes, and revises their own pre-knowledge. We recruited English-speaking participants with a certain level of speech and cognitive functions. The recruitment occurred between July and September 2019 in a stroke rehabilitation unit. We collected the data through face-to-face, semi-structured interviews with 30 participants. This study generated 3 major themes and 6 sub-themes. The major themes are psychological stress, resilience, and certainty and uncertainty about post-discharge care. People with stroke and their caregivers showed psychological stress, which may impact their ability to take over care after discharge. But there were different triggers contributing to their psychological stress. For people with stroke, loss of functions triggered frustration, depression, fear, and worry. They were psychologically unprepared to self-manage care after discharge. This suggested the need to integrate psychological counseling into the post-discharge care services. Caregivers, they were very stressed about they perceived that they were expected to take over care while still struggling emotionally. Not only were some grieving, but also some were facing, for example, financial challenges. They were not confident with providing care at home, and they were unclear about what's going to happen after discharge, basically the plan after discharge. Despite the devastating outcomes of stroke, people with stroke and caregivers also demonstrated resilience. Their resilience was built on the same foundations, such as positive thoughts and support of family and health professionals. People with stroke viewed returning home as a huge milestone in their post-stroke recovery. They generated positive thoughts, for example, by focusing on improved functional capabilities and their goals achieved. Family support also enhanced their resilience. For stroke caregivers, their resilience was built on their internal strength, their past life experiences, their views about life and death, and the strategies they used in the past to cope with stress. Stroke caregivers' resilience may increase their capability, enhance their capability to support people with stroke and overcome challenges ahead in the hospital-to-home transition. The final theme is perceived certainty about the care after discharge. People with stroke and caregivers had a very different perceptions about what was going to happen after discharge. People with stroke build up their confidence through interactions with health professionals during the admission. Most of them feel certain about the plan and care after discharge, although some were unclear. So this indicated that a consistent approach to information sharing may enhance their experiences. Compare with people with stroke, caregivers may have limited opportunities to interact with health professionals and be involved in discharge planning process. So most of them felt uncertain about care after discharge. However, some feel they were well involved. So this involvement highlighted the benefits of a diet-centered approach. As we discussed, stroke doesn't just affect the person who's had a stroke. It is two lives that are turned upside down. People with stroke and their caregivers have shared issues, but they also have their own individual issues. Therefore, it's very important for health professionals to involve caregivers earlier in the discharge planning process so that they're better prepared to face the reality on return home. Thank you.
Thank you, Ms. Chen. That's the last of the presentations for today, and up next we've got questions from the floor, so to speak. But we'll start with the questions from the iPad, which we're just sorting out. Thanks. What's that? So what we'll do first is get you all to sit up the front. Can you show me how to use this? Got it. All right, so the first two questions are for Tam, for Dr. Levy. The first question is, what video platforms have you used or are considering?
Well, the current telehealth platform is Health Direct. So that's been embedded within RAP ambulatory services for maybe since 2015. We've used different platforms, but that's the current one. It probably isn't perfect for running groups, and that's something that obviously we'll be looking at. But we have amazing IT support, very innovative IT team, and they can also use DTN in a couple of the group rooms.
All right. Next one for you as well, which is, how do you talk to people if they're not suitable for telehealth?
I'm not quite sure what the question means. How do you talk to people if they're not suitable? Well, I guess, so people attend the ambulatory services, they have an interdisciplinary assessment, and as part of that, you're looking at their suitability for all sorts of services, hydrotherapy, gym, but also for telerehabilitation. So obviously there has to be, you have to consider safety, communication, would they be capable of managing the technology side of it? So there's a whole lot of criteria that we would consider, but I guess we need to, what we're aiming for, this is more focusing on group telerehab, so it's kind of a little bit different as well. So it's about developing clear criteria and processes around how we can implement group telerehab in a more consistent way.
Thank you. Up next, we've got Associate Professor Michael O'Callaghan. How can we increase screening for younger men?
Good question.
If you've seen the press over the last few weeks about prostate cancer screening, maybe firstly have a consistent message and also encourage it. Right now it's not encouraged and there's a controversial message around it.
Great, thank you. Again, Dr. Levy, which groups of patients do you predict will benefit from group tele?
Well, I think, traditionally the groups that have had most of the research done have been around speech groups, so run by speech pathology. But also, if you're thinking about physio, you're thinking about probably more higher level patients. But it's a matter of grouping people together. There's obviously a huge scope around education and those sorts of things as well. So I think there's a whole range of different groups of people that could participate, and that's obviously part of the process that we'll be looking at, is how we go about grouping people together and what sort of groups we'll be running. We are doing some group tele-rehab, but it's more about trying to develop this further.
Thank you. Ms. Chen, what are some of the strategies you are anticipating you will implement to support DC of the stroke patients and their carers?
Sorry, the last thing.
Support DC. Discharge, got it. Of the stroke patients and the carers. I was having a blank.
I think in terms of involving caregivers earlier in the process, in the discharge planning process, we've already on the ward, as you know that the research is in 2019, we've already implemented we call that brief. There is a poster in this week as well, presenting. So for mild to moderate stroke patient, we identify them and we involve the family early on, within a few days of admission. We have a bedside family meeting and a goal-setting meeting. So we try to answer the question earlier. So I think that's one strategy. I think it is challenging to involve the caregivers because because of my PhD study, I also interviewed them, the health professionals. So from a health professionals' perspective, it's the time. Time is one, and also sometimes caregivers may not be ready. They were still in denial. They were not ready to take on the role. So it's challenging.
Thank you. I'll move to the floor. Any questions from anyone here today? We'll go up to the back there. Sorry, just one comment. We've only got one working microphone, so if you could speak up. Oh, thank you.
Thanks. Tim Schultz from Flinders Uni. A question for Dr. Searle in terms of the difficulties of implementing your screening tool. Is there anything already existing in the EMR that could help to flag patients that have, chronic pain that would replicate the results from the screening tool?
That's something we're sort of starting to look into now. I mean, obviously within Sunrise EMR, there are a number of fields that we're going back to ethics and we're going back to the data, hopefully, to for the chronic pain patients we identified to look at what was actually recorded in the EMR. I mean, there are a number of fields that get recorded. The nurses record presenting complaint. Is this right, Debbie? Debbie, the ED social worker, is probably a bit better placed to answer this. We've got presenting complaint from the nurse.
So when they come in triage, they are recorded by the nurses, the presenting issue, and then the doctors, when they assess, they do the coding of
So we have, there's a couple of free text fields within the Sunrise EMR. So we have been sort of starting to dip our toes in. We'll need to get some ethics amendments in, but we get a sense that we can do searches for, chronic pain, persistence pain within the free text fields, because the ICD coding, it was ICD-9 at the time we did our study. It's now moved to ICD-10. There's not great capacity for recording chronic pain, understandably, because it's an acute care service. So we're thinking we might get richer information from those free text fields when the nurses and the doctors sort of more record their thoughts before they have to be simplified and categorised. But we're also interested to see differences between what's reported at triage to what the doctors ultimately record it as, even just within the free text fields, to see if there is much change from presentation to diagnosis. But yeah, certainly that's somewhere that we're starting.
Thank you. It's back here.
Halfway, and then that's running. Hi there, Diana Voss, one of the patient and family reps here. Fantastic presentations from everyone. Just really interested, Chen, I know it's part of your PhD, and so you've had more interviews. That was just prior to discharge, but you also spoke at 3-month post and 6-month post. I'd be really interesting to have a bit of a discussion about the resilience. You were talking about one of the caregivers to me earlier, that person felt, and how they changed, and how that thinking that they were very resilient and then actually not coping so well at home, and what your thoughts are about how we can support people better when they get home.
Thanks, Dana. I do remember a caregiver I interviewed. I also not only do the pre-discharge interview, this is what I'm reporting today, I also interviewed them 3 months and 6 months after discharge. So I remember a caregiver, she definitely has got a very strong internal strength. You know, she said one of the verses is from her, we only consider this as a change in the road of life. But when I interviewed her at 3 months' time, she was crying, very teary, and said it was horrible because her husband had cognitive and speech, both issues, mainly the speech issues, and she's lost the person completely. But at 6 months' time, she looked at the garden and told me that how beautiful life is, acknowledging that her life has turned upside down. So I think I mentioned that it's very important that there is counselling services in the community, which is lacking at the moment. And also from health professionals' interviews, it's identified that we are actually more focusing on the physical and cognitive recovery, even in the discharge summary. Yeah, so those are the areas perhaps for us to reflect on and see what we can do from our part, and also, of course, in the general health services design part of it, to see what we can do, improve and support them. But I think it's very important if all of us, we are in the chain of stroke care, if we can work together, I think we can support them better. Thank you.
Thank you. Other questions from the floor?
Sorry, I've got a question for Joe. The Eat, Walk, Engage adoption, that looks like it was very, very fast and efficient adoption of evidence-based practice. So can you talk about what other ways we can go about implementing best practice and how we can speed things up, because that's been notoriously, a tricky endeavour.
I'm not an expert in implementation, but I think it is important to use a specific knowledge translation or implementation framework. So Eat, Walk, Engage used the IPARIS implementation framework. So the project showed that it's acceptable, feasible, and the modelled economic analysis was very positive. But the project has finished, so to continue, there needs to be a decision to roll it out. So when there's evidence, it's good to have the framework and look at all the implications for translation and sustainability in practice. So that's, I guess, really the next step. And I was really pleased to report the results today, because it's about sharing the results of the project and the potential that it has for the health service. And so the question is, what next? In Queensland, it's been rolled out to 20 hospitals. So that's positive, and I think it does have potentially huge benefits for our health services. Does that answer?
Thank you. Just a comment.
Sorry, just one last thing, sorry. Me again, Diana. I think what I'd really love to know, as you say, you can see the evidence is there, and you set a challenge to Salin to take up and run with it. What is it that you need to get it in place? You mentioned that you had a sort of a multidisciplinary assistant. Is that the barrier, that there needs funding to have somebody in place to... What are the barriers to actually take it forward? Thank you.
I think resourcing is clearly one thing. So the resourcing would be required for the facilitation and for the allied health, for the multi-professional assistant. I guess one of the issues is that delirium is probably under-recognised in the health service. So it is a huge problem, but it's hard to diagnose, and people tend to shy away from it a little bit. So I'm more a mobility champion than a delirium champion, but good care is multifaceted. And mobility goes with nutrition, goes with hydration, goes with cognitive engagement. It's about our processes of care and some commitment to and interest in the processes of care that we provide. And there's a lot of focus at the moment on the front end.
I've got a question.
So I guess I'm keen to share the results and socialise them and see, what else is there that we need to address. There's resources, but is there a lack of interest? I mean, there are many competing priorities, so working out direction is important.
Thank you. Question for the team representing Prof Heddle. So you guys obviously use the Focus data set and we're seeking to predict or identify outcomes related to medical emergency response. I'm wondering whether it would be of value and whether you'd considered looking at acknowledging that Focus is greater than Salin, but the medical emergency response databases, and whether that might be, are there any particular outcomes that are specific to that would be worth looking at?
Yeah. Thank you. The Salin database alone was massive, and I think it was, yes, if we came up with some meaningful things, we would expand it to the full Focus database. But because particularly because of COVID, we didn't manage to get through all those things we wanted to get through in the time that was available. But it's a good concept to expand it. And to get down to the nitty-gritty question of which are the markers of the hemodynamic instability that say you should or should not give a beta blocker, you may need to go to that bigger database. But we need to have a refined way of searching that, so you didn't waste too much effort looking at all the unnecessary things and just concentrate on the key issues.
I'm also curious to know, because I think Focus collects EQ5D, whether or not there was any sort of evidence related to quality of life that you looked at, with a paradoxical difference perhaps.
No, we didn't. No. We weren't in a position to look at the quality of life.
Thanks. Any other questions from the floor? Ms. Chen, one question I have with regards to your study. So essentially the concept of a dyad from an economic perspective, and I might need Dr. Schultz to help me with this, but is that of an externality, i.e. the idea that the impact might also affect someone other than the individual that's impacted. I'm a paediatrician by background. This is a pretty familiar concept, and in fact, economic evaluation in children is usually measuring parental outcomes, not child outcomes in terms of economic impact. I'm wondering whether or not, I appreciate this as well outside of the sort of qualitative scope that you looked at, but whether if you considered the idea or come across the idea of sort of quantitating that impact on the dyad from an economic evaluation perspective.
article I read, they only talk about like specific to the stroke population. I think they look at the those interventions. They more look at the quality of life part of it, rather than health economic. But it's a good reminder. Your question is a good reminder that perhaps the next stage I could look into that, the impact of that.
Great.
Thank you.
Thank you. Any last questions? Almost up for.
Thank you. It might actually be the reverse. Rather than the parent, it might be the effect on the children in stroke. Anyway, that's a tangent. My question was actually going to be about the prostate cancer registry, and very interesting to see the information that you have about hospital volume. I wonder if you're able to comment whether you're able to separate specifically surgeon volume from team volume. So it's not just the surgeon, but the anaesthetist, the surgical team, the ward team in recovery, the rehab team. All of that contributes to how patients recover. So I wonder if you have any information about pulling that apart.
Thanks for the question. Yes, we were able to do that. So we've done it by institute volume, which would be that team, and also separately surgeon volume, which would also account for surgeons operating at multiple hospitals with public and private hats on. So yes, we've looked at that. They both have an effect.
Great, thank you very much. Well, that brings to a close this afternoon's session. Thank you, everyone, for your dedication and time. And cool. And now it's time to get some food, apparently. Yep.
Okay, we might get started. Come on in. So, welcome everybody. I'd like to acknowledge firstly that we're meeting on Kaurna land, and I'd like to acknowledge the Kaurna people as the traditional custodians of the Adelaide Plains and pay respects to the elders past, present and future. I'd like to also recognise and respect we recognise and respect their cultural heritage, beliefs and relationships with the land. We acknowledge that they are of continuing importance to the Kaurna people living today. So with that acknowledgement, I'd like to welcome you to this session today. Today we're looking at the Health Service Research Day, and we're finishing off with the session on MRFF impact and opportunities. And we've got a great panel, and I'm really pleased to have 4 terrific people who are going to be able to speak to you today. My name's Wendy Keaton. I'm the CEO of Health Translation SA, which is the NHMRC accredited translation centre for South Australia. We've got 11 active partners, of which the health services, all of SA Health and all the LHNs, as well as a number of the primary health networks, and all the academic institutions in South Australia are part of Health Translation SA. We're very pleased to be playing that role at joining groups across the state at a statewide level to really look at how we can make a difference in bringing health services and the research worlds together. And that's what the NHMRC have designed these research translation centres to do, to make sure that they are no longer sitting in separate places, but really bringing health services and researchers together to really have impact, and particularly impact that we can see for patients, their families, carers and others that really need it. So with those remarks, I'd like to acknowledge that the MRFF is a good funding source that we have in Australia now. It's a big funding source, it's a different funding source, and we have to think a little differently about how we work with it. It's been around for 3 years now, or upwards of 3 years. And South Australia has actually been working pretty well more recently around the way we garner and bring together applications for the MRFF. When we first started this journey, 2018 I think it was, we were actually doing pretty poorly. It was only very early days, but some of the other states were doing very, very well already. And we had to think about, okay, what can we do to mobilise South Australia to do better in this space? One of the first things we do, and HDSA was in the position to bring together people from different institutions to say, what are we doing, what can we share, how can we turbocharge it, how can we mobilise, how can we get people thinking about the MRFF? And we held a whole range of seminars to try and raise the profile about what it was and how it was different and what you needed to do. But importantly, what happened was people like Rui, who will be one of our speakers, were representing the different institutions around South Australia, and they were able to start thinking, what do they need to know and how can they actually share information across institutions so that people can really learn from each other and build a culture across South Australia where we all know stuff and we can all start helping each other out about how we lift each other up. And to that end, the MRFF working group has been happening, and we're about to have a strategic review of the MRFF working group and actually think about, is that what's still needed, or do we need to do other things in South Australia? But the good news is there's been a difference in South Australia over those years. I'd like to let you know that from Herd C funding, which comes into the academic institutions, 2018 we had 2.8% of the MRFF funding. In 2019 it went down to 1.8%, and in 2020 it was 9.49%. So hopefully that's not just a blip and we're going to go back down again. Hopefully it's something we're going to all be able to celebrate on an ongoing basis. We also have, just in the last few days, received all the information from the MRFF about all the grants that have been given out over the last 12 months, so we can cut the data again to see what other changes have happened. So I guess I wanted to bring that good news story, and the good news story is important because your panellists today are going to tell you tips and tricks and some of the things that they've learnt on the journey. There are people all over the state now who are skilled and are getting really good at putting in these applications, so we have to learn from those. Have to learn, what does success look like and why are they winning and others aren't? Things like, I've heard this week, consumer engagement, really important. I'm sure our panellists will talk about that. But I've heard it's so important that if you haven't done it and done it well, your application might not even pass to the next stage. The consumers on the panels are going to say, this didn't happen, it didn't happen well, and they get put to one side. So there's things that we must start thinking about in a systematic and very informed way if we are going to actually get to the place we need to be in South Australia. So with those opening comments, I'm going to start to introduce our panel. Today's session really is about building great teams to solve big problems, and that's really what the MRFF's about, and we want to win that money into South Australia. We also want to be part of national collaborative grants, and I know some of our panellists are doing that very well. So, it's not all about South Australia. We want to lead things in South Australia, but we know the MRFF likes things that are national, so we have to look outside our borders in some circumstances. So each of our panellists are going to speak for about 5 to 7 minutes. We're then going to have an opportunity for questions at the end, and then at 5 o'clock we'll be out the door. So if that's sort of the parameters. So please, if you do have questions, please, hold on to them, and we'll make sure that we can have a good chat during the panel. I think with those comments, I think that's all I had to say as formalities. But I'd like to now introduce our first speaker, and his name is Professor Raymond Chan. He's the director of the Caring Futures Institute at Flinders University. And Raymond is also the Matthew Flinders Professor of Cancer Nursing at the Caring Futures Institute. He's an NHMRC Investigator Fellow and is investigating models of care and health service responses to address the needs of people affected by cancer particularly. Professor Chan is very well published and has also attracted an enormous amount of money within his career. So I was very impressed by that number, right? 35 million in excess of that over his career. So really a great job. So look, I think we're really privileged to have the first of 4 great people in this panel coming to speak to us, and I welcome you to the stage.
Thank you, Wendy. Thank you for the kind and generous introduction. Ray Chan, Director of Caring Futures Institute at the College of Nursing and Health Sciences at Flinders University. A 30-second pitch about the Caring Futures Institute. Who are we? We are 300 dedicated researchers that include students in really trying to translate knowledge, generate knowledge and translate knowledge that will result in better lives, better care, better communities and better systems. Today what I thought I would do is to use my 5 minutes to reflect a little bit about our successes and actually some of the thinking and reflections around those successes. I've been fortunate enough to get a little share of that MRFF funding, both as CIA as well as a CI on larger teams. And the first 2 is around nurse coordinated and nurse enabled care that would allow GPs to care for people with cancer, as we realize that in the acute care setting, we keep having more and more people aging, more and more people getting diagnosed with cancer. Our clinics are not coping. How can we actually make sure that these people have their needs better addressed with our colleagues in primary care? So there needs to be a lot of thinking that goes behind all that. We can't just push care out for the sake of pushing it out. What is the rationale? What are barriers? How do we overcome those barriers? It is a big problem in Australia. Because we are having 1.1 million people living with cancer in Australia. It is definitely a problem that we all need to cope with. So I only have 1 slide to share, and hopefully I can actually allow more time for us to discuss a little bit further. When I think about the success of our work, it is really around working within an interdisciplinary team. And we use that word a lot. We try to have people from different disciplines. We try to have consumers on the investigator team. But when it comes to how we actually operationalize these ideals, as we start to put consumers on our team, you start hearing people talking about, well, should you put them as an AI? Is one consumer enough? What about a policy person? How would the policy person contribute? What happens if the policy person doesn't have a research track record? Do you still want to put them as a CI? How would all these people come together to really, really help us solve a big problem? So I think that this is something that requires some unpacking for us on the panel, hopefully. But certainly, those are some of the things that we have to grapple with going forward. There is no one single discipline that is going to solve all the health problems, and we need to think about how we can work together. And I sort of nearly get excited when I see these undergrad students doing interprofessional education, when you actually put people from different disciplines coming together to try to solve a big problem. What could people potentially come up with? And I consistently challenge my nursing colleagues, do not just think about a nurse-led care. Go back to the problem and think about how we can propose something that is truly transformative. And so that led me to the second point around how do we propose something that is really not just the next logical step? How do we, of course, we all are very invested into our programs of work. We are trained to come up with a systematic approach. We do step 1, and then we do step 2, and then we do step 3. You run a phase 1 trial, and a phase 2 trial, and a phase 3 trial, and a phase 4 trial, and you want to introduce system sustainability. But how do we practically, being the best that we can be in research quality, yet actually propose something that is truly paradigm shifting, that is not just about playing safe, that is not just being about the next logical step. And as a reviewer, I do think that sometimes, yes, the next logical step is this and this and that. That sort of gives me some reassurance that the person has done enough pilot work, but is it paradigm shifting? Really thinking about how our proposed work would align with political agendas and policy, and also discerning about how what we propose really align with the particular missions or the particular intent. Many people don't necessarily read through that evaluation document of the MRFF. It's something very, very good to get your teeth into, to understand where is MRFF really coming from? How do they know that they have achieved successes from an MRFF funding perspective? Then you would actually see why it is so important for you to make sure that your EMCR has a key role in your application. We all actually see now that they are doing surveys with the EMCRs about how truly engaged they are, or are they actually just being named on applications. So we're beginning to see MRFFs looking into many of these things. Of course, the basic grantsmanship, they all apply, but when we think about putting the best teams together, the best in the nation, to solve a big problem together, I'm still seeing people playing safe, trying to engage people that they have done previous work with, rather than really putting the best team together. So I still think that is something that is important for us to think about. In terms of scientific quality, what is really the cutting edge? Can we use potentially, if we are talking about health services and health systems research, are we using adaptive trial designs enough, for example? Are we really thinking through all the methodologies that are available to us in the area of knowledge translation, for example? Lastly, how would your application stand out from others? And one thing that I tried to trial in one of my applications was to put a budget item for policy fellows. We actually promised in the grant that we will be asking 3 doctors or nurses or allied health researchers who are EMCRs, and we will be partnering with policy research organizations to give them policy fellowships, whereby they will be taught how to write policy briefs. They will be taught how to interact with policymakers, for example. So that's just one thing about how you potentially are proposing something that would really make your application stand out. But there are many ways for you to make your application stand out. And lastly, of course, is risk management. And I think that is one page and one area that I feel that a lot of people are leaving to the last and not necessarily spending enough time on it. So I just thought I share with you my thoughts.
Great slide. It covered off a lot of things, and I just think the ability to really be focused on the problem that you're actually addressing, but bringing together those great teams that can really address the problem in a way that, as you discussed, and I love the idea of policy fellows, and we've actually used translation fellows, we've used data fellows, and I think that bringing that into it gives that level of recognition and also is that point of difference. So I liked some of your thoughts very much, and how you actually get the paradigm shift. I think that stuff is really important to focus on. So thanks, Ray. Thanks very much. So hold your questions, but please do make a note of them, and we'll see where we can bring this all together at the end. So now I'd like to welcome Dr. Rui Hu up to the stage. She's the Research Support Lead for the Medical Research Future Fund at Flinders University. She has expertise in research development and grant strategy, and I've got to say, Rui has been an absolute breath of fresh air to South Australia, and I really welcome and just acknowledge the great work she's been doing. So with that, come on up.
First of all, thank you for the invitation to be on this panel today. My name is Rui, and I'm the MRFF Research Support Lead at Flinders University. So in one sentence, what do I actually do at Flinders? I basically help researchers to win MRFF funding, help them to position for funding, and as well as to execute strategically during the development of a proposal. So Medical Research Future Fund, MRFF in short, has been established in 2015, and they actually start rolling out their schemes and initiatives from 2016-17, and slowly they are fully capitalized right now. So they have about $6.3 billion in the funds for the entire next 10 years from now till 2032. So that's a lot of money, about $650 million being dispersed every year across the country for a variety of grant opportunities. So MRFF has evolved. Many had thought that it was a black box when it first established, which is quite true. It's highly political. It's complex to navigate. It has a very short turnaround time. Some say 2-3 weeks, and only some people benefited from the schemes. Those people who know about it benefited from it. MRFF, fortunately, it's very responsive to the entire sector and has been continuously improved themselves through the feedback from the sector. So I was just thinking on what are the common perceptions that has been formed because of the previous experience, and what has been changed, and how do we address them strategically moving forward. So some common myths, short turnaround time, no longer that's the case. I think for the last at least 18 months, MRFF has been opening their calls for at least 6 months. And the intent is really to gather the best proposals from the ground, from the entire sector, to provide the best solutions for Australians, community, and also health systems. I came from New South Wales, and when I first arrived in South Australia, there's a common notion that there are big wins in Victoria and New South Wales. There's a lot of strong bias in that. But I thought of just looking back into the data and look at just across a few years and see what's the percentage share across health and medical research funds from both MRFF and also NHMRC. So there are actually quite some similarities, around 6% to hovering to 8%. So whether we can actually double that, I'm pretty sure absolutely yes is my response. And we have seen significant growth, especially in Flinders in the last 2 years. Same opportunities will come next year, will come again. That's actually not always true. So MRFF is very priority driven, and what that actually means is every time a funding opportunity comes up, there's actually some context to that. So there's a reason to it. There's unmet needs that's been gathered from the sector, and so they come up with specific targeted calls for specific initiatives. So my advice is to actually seize the opportunity when it comes, because it's likely and sometimes highly unlikely that it will come again. The last one is we should always apply if the call is in our topic area. Or some would ask about whether I can actually repurpose my previous unsuccessful grant into an MRFF grant. My advice is to say that it's not always the best strategy. The reason being that it's kind of difficult to fit a square peg in a round hole. So it's always good to adapt and refine and revisit the strategic considerations and whether the ideas and the team itself is actually fully aligned with the specific intent of the call. So we have some good news from Flinders, especially it has been under embargo for, I think, 2 months. We are very, very pleased to that the embargo has been lifted last week, and Flinders has been successfully awarded with 6 MRFF grants in the last rounds. When I say last rounds, means whatever grants that we have submitted early this year, we have 7 being awarded, actually, considering with Craig. I was just forgetting about that, sorry. We have got 7 including Craig. Sorry, I keep forgetting because I have been reporting to the DBCI recently quite a lot that we have 6, but actually not 6, 7. And more pleasing is that since July 2021 till July 2022, all our Flinders submissions, we have 50% success rates. So every 2 grants we put in, we have 1 successful grant. So that's extremely, extremely pleasing for Flinders University. And our challenge right now is to how to maintain that and how to actually grow from that. I'm a little bit reserved. I'm a little bit more conservative. I think it's a bit part luck, part preparation, part opportunities. So let's see how we go moving forward. So I just thought of sharing a few strategies that we have in place in the last 2 years to actually uplift the MRFF performance. The first thing I think is really, really important to in my work is to really engage with the research and clinical communities, engage early, proactively and broadly. I have to say that one of the tactics that I thought had worked is that we have never picked winners in this process. So I know a lot of universities, especially in the GO8s, they pick winners to support because of just the sheer volume and the track records of some superstars. But at Flinders University, we thought of giving everyone a fair go, and we actually focus hard on capacity building, working one-on-one with applicants despite them being early career, mid-career, or senior researchers. We engage as much as we can, and we build capacity and try to guide them how to win grants. That's quite evident in our successes. We are very, very pleased that a lot of our winners are actually early and mid-career researchers who had never won a grant before. Some of them have less than 20 publications, and they managed to pull together fantastic ideas and teams to actually get awarded. I think that's a good start, and I'm sure more will come later. one of the important things, people with good ideas, we engage. And one of the things that I think in medical area, it's early intervention. So we engage early and intervene early to make sure that our applicants and researchers are actually aligned and stay on the track with their ideas and the team to target the specific objective or the outcomes that are requested or asked from the MRFF. So we help researchers to align and adapt their concepts to and be agile in that process. So to adapt again, whether to be more translation focused or more proof of concept focused, and just to keep things simple. That's one thing that I realized that in MRFF, it's always important to be simple. We empower researchers, clinical leaders to drive that process. So again, going back to the point about building capacity, we really empower especially the early and mid-career researchers in this journey. Many of them had came back to say they almost wanted to give up because it's really, really difficult and challenging to wrangle and coordinate with 15 chief investigators and probably 10 partners. And it's just so challenging. And this is their first attempt. And we stay with them in this journey and support them as much as possible. And one of the pleasing things that I heard from one of the early career clinicians is that it's actually not too bad after all. So, yeah. And lastly, I thought it's really important is really just to foster and build a culture in the university together with Salin to achieve research and clinical excellence. It's not just about completing an application, but actually making a compelling application. Really trying to inspire bigger thinking, not just about South Australia, but nationally, what's important across the country. What we observe here in Salin is likely going to be observed in other local health networks in other states, and how do we change practice at scale. Lastly, is about the peer support, and I have to thank our panel members again that has been very generous in all this time in sharing their experience, in supporting applicants who are more junior, and really helping them and guiding them in this journey. So I'll just end there, and thank you so much.
Fantastic, Roy, and I think your experience is just oozing, so thank you so much for that. I think the specific objectives of each of the calls must be really drawn to people's attention because they are really different, and you have to really look at the detail and really respond to the detail about those specific objectives. I loved you saying keep it simple, and the MRFF does want to be able to, anyone needs to be able to read them. Those applications, they're not applications that are going to just be read by people that have a heavy-duty academic bent. It's actually for everybody. And I love the way you talked about empowering, because that's what it's all about. It's about empowering the whole community to get on board. There is a lot of money around, and it's a lot of money for a while, so we need to keep on that journey to get it into South Australia. So thank you so much. The other thing I wanted to mention is when you do look at the MRFF, and there is new strategic priorities coming out for 22 to 24, and new priority populations, and the word on the street is that for all the grants, they're actually going to be looking at kind of matrixed with the priority populations cutting across them. So it's good to think about what we're doing in the priority population area, and also in response to specific challenges that are around climate change, for example, COVID, for example, specific challenges. So it's good to really have a look at that detail. So thanks so much, Roy. Okay, on to our next speaker. It's Professor John Carnan, and John is the Professor of Health Economics in the College of Medicine and Public Health at Flinders University. He has a strong interest in developing the use of health economics by local health services such as Salin, where his team have undertaken lots of local economic evaluations. So we're really pleased to welcome John to the stage to share his vision around the MRFF. Thank you.
Thanks, Wendy. There we go. Actually, as Ray was talking, I realised that I don't think I've spoken at the same session as Ray before, and we're representing different research institutes within Flinders. So, as Ray was saying, he's representing Centre for Caring Futures Institute, which is the research institute for the College of Nursing and Health Sciences, and I'm representing Flinders Health and Medical Research Institute, which is the research institute for the College of Medicine and Public Health. So, but it's certainly in the area of MRFF, and more generally, the collaboration is the key. And so there's a lot of collaboration between the two research institutes. They don't think that you have to approach one or the other. We work together very closely. So my role is I'm one of the deputy directors of FIMRI, and in that role I've worked very closely with Rui, but also with the great research development support team within the College of Medicine and Public Health to support researchers and clinicians to develop competitive MRFF grants. So I've been involved in quite a number, both successful and unsuccessful applications over the last few years. And so the first point I really wanted to make was that having that strong both clinical on the ground input to MRFF applications, but also strong research background is imperative. Without that, you're not going to get anywhere. And that's true of health services research in general, but particularly around MRFF. And whether a project is initiated or led by a clinician or a researcher is not that important. It varies from grant to grant. You choose the team, you choose the leader based on capabilities within the team and requirements of the grant. But I really want to emphasise that clinical input is critical, and the two kind of areas I've identified as where it is critical and give some examples around, firstly, the research focus or the research question. So Rui mentioned the point of care testing grant that's just been announced last week. Well, we've got a really strong point of care testing centre at Flinders University, and they deliver a lot of point of care testing across Australia. But they're primarily researchers, and when this call came out, we couldn't have written the call to be more appropriate, more relevant for our point of care testing team if we'd have wanted to. So we came out with, oh, great, we've got to go for this. But the first thing we did was get in touch with clinicians and get them on board, firstly, but then really talk to them about what are the areas where point of care testing can have the biggest impact in rural communities, because the focus was rural communities. And through that process of engagement, we identified sepsis as being a real area of unmet need with really severe clinical consequences. And so that became the focus. And then we worked with the clinicians to understand the pathways that are currently used to identify and diagnose and treat sepsis in rural areas, and develop the intervention to address those issues. So that was critical in defining the focus. The second example is around research scale. And so this I'm drawing on a recent application, so we're still waiting on the outcome, that was led by Cameron Phillips, who's a pharmacist here at Sarlan. And he was very interested in the use of home medication reviews. So he's a hospital pharmacist, but recognises the need for home medication reviews for patients once they've left hospital. So that was his idea, and we worked with Cameron to develop the research questions and the research methodology, and he contributed fully to that. But what he really brought in addition to the project was his networks. So he was fully engaged with the pharmacy scene, as you might call it, around South Australia, and was able to bring on board pharmacists and relevant clinicians from across the network. So it really led to a statewide grant application, which I think is a really strong application. And having that statewide, if not interstate aspect to these MRFF grants is really important. So a grant that's just purely focused within Sarlan is probably not going to be competitive. You need to go beyond Sarlan, across the state, ideally interstate. As Wendy mentioned right at the start, consumer input is critical to undertake research that's going to have impact, to identify issues that are of importance to consumers, because that's ultimately where the research is having its impact. And actually, the pharmacy application is another good example of how consumers can be involved. So a consumer is actually a chief investigator on that grant, and she's been involved in the development of that application from the word go, and had some really important insights into how consumers are going to react to the intervention. What are the drivers, the mechanisms through which the intervention is going to have the best effect on consumers. Rui talked about timelines, and yeah, really in the early days it was just crazy. You know, the call would come out, you'd have 4 weeks to get your whole team together, write the grant application, and these grant applications aren't short, so it was, you know, a real barrier. But as Rui said, that's really improved over time, and now you've got, you know, 6 months from when the call comes out, and so really it's critical to not think, oh, I've got 6 months, so I can get to it next month. Start early. Get your team together, get your team engaged in the process. So a common method we use is we will hold a team meeting really early on, get everyone together so they can meet everyone, because often you have people who haven't met each other before. And then once you start writing the grant, you get it up there as a SharePoint so everyone can access the grant. And then you can kind of point investigators to parts of the grant where you think they can provide the kind of input that's required. And we've found that works really well in terms of getting people engaged and basically getting a really strong application together. The final subsection here, you miss 100% of the shots you don't take. Is anyone familiar with who made that quote?
Maybe a basketball thing. Yeah.
Ice hockey, actually. Ice hockey. Wayne Gretzky. He was talking about ice hockey, but I'm talking about MRFF. But I do agree with Rui that you shouldn't go for everything. And that's, I guess, what I'm saying here is, firstly, you've got to think big and bold. And what we're interested in is drawing ideas from the largest pool possible. So we want to engage with as many people, researchers, clinicians as possible to get those ideas, and then we can funnel them to the ones that we think are competitive. So I've said here, Rui will ask the right questions. She's not shy. She won't tell you the idea's rubbish, but yeah. All right, maybe she will. Maybe she will. But she'll be very polite about it. But once we've identified a competitive idea, then FIMRI, but also Care and Futures Institute, our purpose is to provide the support that you need to develop your ideas into a competitive research application. So please be in touch.
Fantastic, John. Thank you so much. And I'm sure we'll grill you when you get on the chair and the panel. So thank you very much for that contribution. And I think you can just see those clear points of what's needed to get these things successful. I just wanted to let you know there's 119 people online watching the session as well. So that's really pleasing. So your words of wisdom, I'm sure, will be taken on board. So our next panellist is Associate Professor Craig Whitehead. And Craig is the Clinical Director of Rehabilitation, Aged and Palliative Care at Salen, and so we really welcome him and for him to share his expertise with us. Thank you.
Thank you. Thanks, Wendy. I'm a little bit underqualified to be here because I don't have a slide, and I'm the only one I don't have a higher degree. Oh, sorry. No, I don't have it. Well, it's all right. You can keep watching John's slide. So I'm a clinical director. I'm still a clinician. I do see patients, but I've been involved in quite a number of MRFF projects, and we've been, I guess, modestly successful in a range of things. And I think there's really there are really three key messages I'd want to give. First of all, one isn't something that you do, but is something that's really important. And that is, I work in a department that has a clinical academic, that has a strong focus on quality and quality improvement and knowledge translation. And that environment means that the clinicians who work with me, and whether that's our nurses, allied health or doctors, we're actually focused on trying to do things better. And I think if you want to do MRFF or you want to participate in this, you need that kind of genesis to start with. You need to have the right fertile ground. And I think the state government, particularly the Department of Health, tends to greatly underestimate the importance of those clinical academic roles in actually generating not only new ideas, but patient improvement, quality improvement. And having that kind of fertile environment's probably been, well, I wouldn't be here if it hadn't been for Professor Maria Crotty, who's our clinical academic, and she's generated countless research careers. And so I suppose that's an environmental thing. You can't all do that as a clinician, but it is, I think, critically important. In terms of what you do, there's really two main things as a clinical person who's in these projects. The next one is you've got to work your networks. That's really important. Now, those of you who know me know I talk a lot, and I often talk to people a lot. I often stop people in corridors and I ask what they're doing. Now, anyone who I speak to in the corridor, please don't feel I'm sizing you up for potential inclusion in an MRFF grant. But I don't think you can underestimate the importance of those. I've never underestimated the importance of those connections, which sometimes lead to nothing, and it's fine. But sometimes you'll talk to someone and then an idea will happen, or you'll have met someone who you think, oh, actually, they might be interested in doing this. And not only when I say work your connections, and that sounds a little mercenary, I think it's very important you do it the other way around, that when people come approach you and say, could you help me? You say yes. And, you know, I don't think there's none of those interactions are wasted. And not only, at the very least, you learn something and you meet someone new, so that's always important. And I think as a clinician on these grants, one of the really important things we bring is those connections, those ability to connect different parts of the health system, particularly the areas we work on. You know, I've got connections in the aged care sector, we've got connections interstate, we've got connections with other geriatricians, got connections with allied health practitioners, and between us we can bring a lot of people around the table. And certainly when the couple we've won working with Geraint Rogers, who works through SAMRI, has really been by chance, because he talked about something, he said, that sounds like a good idea. And then we got together and he brought a team together and we were able to bring components of that team, and that helped us get the grant. And the last thing is, as a clinician, I was trying to reflect the best way to say it, but it's probably really active listening is the important thing. So when I'm approached by researchers, or a member of a research team comes, or Maria comes to me, or one of the other comes and says, well, there's a grant coming up, is to listen to what people are thinking. So if someone brings a proposal to me, it's really important I understand what the researchers are trying to do and trying to get into their head and understand what they're thinking. And then I can give them advice about whether it's clinically feasible or not, the right way to access the patient population. But you've got to understand what those researchers, and often we'll have people who'll come to us they're really passionate about their idea, but you've got to be able to make them explain it to you in a fashion that you can then feedback. So I think that listening and engaging with researchers and understanding how researchers work as opposed to clinicians work is a really important part of what I do, is to try and create that gap. And I think those are probably the three main things that have probably contributed to our MRF success. So I've been short and succinct, Wendy.
Fantastic. Thank you. We like short and succinct. Very good. But some really key points, and I think that clinical engagement. And I've got a question for you now for when you get up on the high seats. So I'd like to invite the panel to come and sit up on the panel chairs, and then we'll get started with some Q&A. Now, is there questions coming from the? Thank you. Good work. If there's any questions online, hopefully someone can find those. I don't know if I'm going to be able to, but if there is, let me know. Okay. So please think of your questions. And has anyone got anything to kick off? Or I've got a couple that I'll start with. Okay, I'll get started. But if there is any others, thank you. I think they've got some mics, and then we can pass that one around. No, I think we need that as well. We might have to pass that around as well. Thank you. Okay, let's get started. We're going to start with question for Ray. And I'd like to ask you, how do you best determine the scope of an MRFF grant?
Wow.
It is a challenging question. Maybe I'll reflect a little bit on our experience. The two trials that I mentioned just now that use nurses as the linchpin to glue systems together to connect acute care and primary care together, they all started off with an idea of nurse-led clinic. And what we found was that we actually keep going to NHMRC, and NHMRC didn't get it. NHMRC didn't think that it was exciting enough. And at that point, I then actually gone through the transformative process in my mind about what is really truly transformative. How would we really change the system in a way that would give us the result that we want? And it is a long shot because everyone would tell me GPs are so busy. How can you possibly just add another thing to their workload? And we thought of 10 barriers of why it wouldn't work. And then that was when I actually start thinking that, well, it's great having those barriers and knowing those barriers, because now we need to address those barriers, and so we can actually bring forth change. And I guess it's a long answer to a short question. How do we actually determine the scope of the project in a way that will address a big problem? And it's really not an easy answer, but I guess allowing others to challenge our thinking, getting people from the interdisciplinary and multidisciplinary team to challenge our thinking. Are we pitching at the right level? Are we being paradigm shifting enough? I guess asking ourselves those questions may give us the answer about whether we are pitching at the right scope.
Thank you. I've got a question for Craig, and it kind of goes on from there. You talked about active listening, Craig, and about how you were listening to see whether you liked the ideas or the ideas resonated with the researchers that were coming to you. I guess my question is, how do we get the questions coming from the health services and actually you identifying the problems and then getting the academics to come and help you solve those problems? So sort of pushing it the other way around. How can we do that better?
That's a great question, Wendy. That's tricky. Look, I think there's. I mean, the first thing is, I think if you've got the right building blocks in whatever clinical structure you're in, where you are reviewing what you do, you're looking at the quality of what you do, you're engaging in understanding the current research, and particularly in a health services point of view, how services are structured and organised. And we're very fortunate that we're able to do that and that we get exposed to a lot of information. I think the questions come very easily. I do think the big challenge when you're coming up with the questions, though, is really the scope question that Ray has answered. You know, when you first start one of these grants, there's a whole lot of sitting around in a room, and it's very frustrating because people will throw these ideas and then there'll be this sort of lull after about 15 minutes and think, gee, that's a crap idea. It's really not exciting enough. What's the what if? Yeah. Have we done big enough? And although I think one of the problems is about a lot of the ideas that will come from the floor often they can either be so complicated and impossible to answer, or they can be such small scope, and it's trying to elevate them to that slightly higher level where you actually can walk away from saying, actually, that's going to make a difference and that's really important to answer. Sometimes I've found, talking to some researchers, that actually they underestimate the clinical significance of what they're looking at, where we say, actually, geez, we really want to know that. And I think... So that very early part that John mentioned in his talk about where you've got the team in the room and you're throwing the idea around, you have to let that percolate for a while. If your basic clinical structures are right and you're hearing questions from the floor and you've developed a set of inquiring minds around you, I think you'll start to get good questions from the floor. I think the challenge particularly for the state health system is that it doesn't... I don't think it puts a dollar value on that level of inquiry, although we know absolutely that better quality occurs where you've got inquiring minds on the floor. So I think, and one of the things that's great about Silent is that It has got a quality improvement framework where it trains us when we put lots of people through teaching them how to do quality improvement. And that probably helps getting some of those basic research skills and basic asking questions and keep asking to get the right questions. So I think that's probably quite an important organisational strategy to get better ideas, better questions from the floor. But it's about having really the right forum and about, you know, good relationships and respectful relationships between researchers and not, and being able to get those people in the room, because it's that first hour or 2, 3 or 4 where you're kind of kicking the idea around and you get frustrated in the middle of it because it's not quite right, and then eventually it clicks. I think those ideas are really born. I think it's a bit simple to say it's just from the floor. I think it's the interaction between a health economist, a clinician, a speech pathologist, or whoever's in the room, and bringing those perspectives together. That's actually what's quite exciting about it, to be honest.
And so it's really setting up those opportunities for those things to happen, isn't it?
Yeah, and I think that's really important, that we can actually get together with our basic scientists and different disciplines and talk about our problems.
Yeah, right.
Can I just ask Craig a follow-up?
Sure.
Yes.
Craig, how do you manage that dynamic, though, with a whole bunch of different people in the room, and these are big groups of people?
I'm probably not the right person. I mean, I don't know in a way. I suppose I imagine it's how kind of, when someone sets up a new play or an artistic collaborative and they kind of have one of those workshop-y things where they sit and talk and everyone, which is so completely not what I am. I'm a scientist and I went through university. I've never done anything artistic in my life. But there is a sort of creative energy. I mean, to be honest, I think part of it is inevitably people form groups of people they can work together. And it doesn't really matter necessarily what the discipline abilities are, but you will always get that set of people where ideas gel and mesh. And we've been very lucky in our division that, we've accumulated and people have accumulated us so that we've built networks of people that we know we can have that creative experience with. But it is, I don't know how I think it is genuinely like writing a play or...
Yeah, I agree. I think there is actually opportunities where you need to bring people together and get them to actually spark off each other and create those opportunities.
There have probably been 1,000 people I've met and I've talked to where it just hasn't sparked, but there have been others where we've kind of, something's clicked. I hesitate to speak about John's wife, but she's also a health economist because John's here, of course. But I commonly say to people, I heard Julie present once on health economics. It was the first time I understood a health economist. And that was really important for me because I could relate to what she was saying and I could understand. And John, you have done the same, but I heard Julie speak first.
That could be a good segue onto John. I think you wanted to say something in this conversation. Was there something you wanted to add there?
No, I was really interested. I guess I'm wondering, when an MRFF call comes out, is that when you get people together? Or
yes. Yeah, well, it's usually when we hear the call, and we obviously, usually we know when it's going to be in an area where we think as a clinician we can deliver on. And I'm probably not going to do research on something in paediatrics, let's be clear. But if it's something about aged care or dementia or acute care of older people, or and there's been lots of calls in that area, we would feel actually that's something we feel we can contribute to. Now, rightly or wrongly, I think as a clinician it will be, we don't add a lot of kudos if we add it to an area that we have no expertise in, I don't think.
I guess I was thinking more broadly across Ireland, there might be capacity to do that more.
I think absolutely. I think we've been very fortunate because we built some connections, but you could do it much more deliberatively. Yeah. You could actually bring people together much more deliberatively.
And I think there is an opportunity to do that at even a higher level, at a state level as well. So I think there are some things to think about. Pete, did you have a comment?
Yeah, look, thank you. 4 fantastic presentations, thank you. One common theme that came out across all of them was the importance of the team. And Craig, you presented in the terms of your network helping you get that team together. And John, you were talking about the importance of a statewide team, but perhaps even a national team. My question is about how important it is to have an international focus on MRFF.
Who would like to have a go at that one? And Roy, good opportunity. Give her the mic.
Thank you. Thanks for the question. It's often good to have international collaborators, but a lot of the MRFF grant opportunities are targeted to health problems in Australia and health systems in Australia. So that's the challenge because of the different health system across different places, even across different states, sometimes can be difficult. And so I would say it's based on the rules, they are allowed to be part of the team, but they are not, I would say they are not critical.
Good, it's a great point to cover off on. But I think reaching out nationally and having some vision, so everything's not. And I think someone made the point that just doing something in Sarlan is sort of a bit too local, but broadening it out and then but bringing in that expertise nationally. Yep, Ray, please.
I do want to say, Wendy, when I was on the panel for MRFFs, I do start penalising people who are putting together a Victorian team or a Sydney team, and I start penalising them with the rationale that they are not going to have a national scalability, because it's just about very well-resourced cluster in the eastern seaboard. So I think it's very important that we have interstate teams.
And I think also thinking about rural and remote need, and that they're not just metropolitan teams would be a guess.
I'll just add on about the international collaborations. There are specific opportunities from the MRFF that speaks towards international collaborations, especially in clinical trials. They are looking for international clinical trials. So whether we are leading one or there's actually a significant and large consortium that's running across internationally, and MRFF does fund that. So in that particular scenario, that international collaborations are critical.
Great. Thank you. Any other questions? Yep. This will be our last question, then we'll do a quick wrap-up, so I'm going to prepare you guys.
You mentioned it briefly, Wendy. Is climate impact at all beginning to be part of the assessment suite?
Yeah, good question. Rui, do you want to take climate something to do with climate?
That's very, very possible. So MRFF is again, it's priority driven. So if there is a lot of feedback coming from the sector to say that they are seeing climate as a huge problem in the clinical settings or patient population, then I'm sure that there will be something coming out in the future. So on that climate, so I know of a researcher named Oli J who used to be in Sydney University and he has moved to Monash University. He was instrumental in lobbying, probably I shouldn't say that word, but actually trying to galvanize the entire community to say this is a huge problem in health. And that has led to NHMRC coming up with a targeted call on that one. So that happened probably 2 years ago, and I'm sure that kind of work will grow, but how significantly, it's a question.
Yeah, I can let you know that in the 22-24 priorities that are still in draft, there is some mention of climate change in them as challenges that would be considered. Doesn't mean there will be a call, it means that it's a challenge that might be considered. So if you did bushfire work, there's stuff there that would fit into those sort of things. But again, it's the detail of the call. Now, we've only got no minutes left, so I'm going to ask each of the panellists to, in a very quick couple of minutes, to your key thing that you would do for MRFF. So start with Ray, your very key take-out message to the crowd.
Very key message is to start early. I just reflected on the 2 grants that I led. Each one of them I actually started preparing the round before, so I knew that the round just has been announced. I actually started preparing for the next round for both the primary care one and the rare disease one. So I would say start now, have the conversation super early.
Great, start now, first message. Rui?
Engage holistically and have patient outcomes as the centre of your ideas.
Great. So engagement and patient outcomes. Craig?
I've got my microphone on, off feedback. I think it's about managing and getting the right team together and just building those early conversations so that you've got all the right people in the room. I think that's probably where we've been most successful, is where those first few meetings have just really clicked. And I mean, obviously all the others are key, but I think it's about managing that team and the team conversation.
Excellent. And is there anything left for you, John?
No.
Health economics, don't let me say.
I would just want to emphasise that we've had a lot of success to date and working with clinicians based in Salem, but I really feel like we've only just scratched the surface.
Yeah, I agree.
And there's a lot more that we can do to work with Salem and the clinicians at Salem to identify those big and bold ideas.
And I was joking about health economics, but it is an important part of the MRFF round. So we haven't really touched on that much today, despite having John in the mix, but I think that's another important thing. So with that, I'd like to close the session and just to say thanks, Simon, for and your team for pulling today together. I think it's been a great day, but also a fabulous panel. So thanks to the four of you. Please put your hands together, and that's it.